All right. Good afternoon, good evening, good morning. How are all my friends? How are you guys? I missed you. I still wish I could see your picture. Are you learning something? Are you learning something? Are you having a good time? As good a time as you can have in this. Is it Thank you, Zia. That's very nice. I'm sorry, Diamond. It was a rough day. Jose. All right. Very, very good. You guys are great. You know, listen, I want to tell you guys something, and I want you to listen very carefully. I want to tell you how impressed I am with you. Meaning, in addition to understanding the science and going through all that, you have a real good handle and sophistication when I tell you stories about events and how you deal with it. I just want to tell you that I'm very, very impressed with your sophistication, much more than when I was your age. I mean it. And so I'm just very, very impressed with you. And I think that I want you always to remember that my role is not just to teach you. I mean, if someone just got up here and just started telling, I mean, it would give you facts and stuff, but the most important thing is you have to learn from my experiences. Because, guys, someday you're going to be in my position, and you're going to be teaching young people like yourselves. So I applaud you. I'm impressed with you. I applaud you. You seem to understand my stories in a very mature way, and I have to just tell you that I'm impressed with it. I wasn't that way when I was your age, and I just you're very kind, Alicia. Thank you. I really want to give you the best experience you can. In addition to the knowledge, I want you to know what it's like to be a physician in years of practice, because that's what will make you great. Does everyone understand that? Does everyone understand that? All right, very good. You guys are a good group. All right, thank you very much. Mark, that's very nice you say that. Thank you. You're very, very good. I wish I could see your faces. I wish I could be with you in lecturing. Okay. All right. Now, tell me what everyone did yesterday night and today. Go ahead. Come on. Come on. Tell me. Laundry? A lip sync battle? Zia, what kind of thing is that? On television. Okay, all right. What else? What else? Wake up, everyone. Come on. Type me. Tell me what you're doing. You shadowed your pediatrician. Very nice. Read Thomas the Train. Eric Clapton. Oh, my God, you love Eric Clapton. I love Eric Clapton. Very, very good. I'm impressed. Attended a birthday party. So, Zia, you like to? Oh, fantastic. Did 20 surgery. You guys are all right. All right. Guys, let me ask you a few questions. When you put ultrasonic neb or humidification as part of pulmonary toilet, what are you preventing? In specific, all right. Very, very good. Very good. 7 days after an operation, if you feel this thing in the wound, you know there's pus there. What is the word I'm talking about? Very, very good. Okay. What are the two things that acidosis does to your heart? The two things. Increase ectopy and decrease inotropy. Is that good or bad? Bad. Generally, which is worse, acidosis or alkalosis? Acidosis. Very good. What do ulcers, do perforators bleed and bleeders perforate or not? No. Very, very good. If someone looks prostrate, are they healthy? Tell me a disease where someone looks prostrate. Boerhaave, sepsis. Okay, very, very good. If you have an ileus, toxic megacolon, very good. If you have an ileus, do you have pain? No. Good. Should you rush in and operate? No. If I tell you abdominal distension, cramping, vomiting, and no gas or poopy, what do you think of? Obstruction. Very good. What's the most common cause of small bowel obstruction? What's the most common cause of large bowel obstruction? Very good. Cancer. Do you have to evaluate the whole colon when you have a colon cancer? Why are you evaluating it? For what? Synchronous tumors. Or what's the operation you do? Oh, you guys are great. The incomplete compensatory for acidosis is what? The respiratory. Very good. What is the complete? If you are acidotic, what are you shooting out? Hydrogen. Very good. Urine follows serum. Very good. What is the most common cause of hypokalemia? Vomiting. What's the most common cause of alkalosis? You guys are perfect, okay? In Ogilvie syndrome, which portion of the colon will explode? The cecum, because of the law of Laplace. Absolutely perfect. Very good. And if you have a patient who you think has an anal fissure and you can't see it, you can't observe it, what must you do? EUA examiner. Guy, you are super. I can't catch you on anything. And one more thing. If you have a perirectal abscess, do you get right in front of it before you drain it? No. No, no. All right, very, very good. Guys, you did fantastic. That was great. All right. Okay, now, let's give yourself a, come on, applaud, come on. I mean it, guys. I'm very serious about that. I'm not kidding around. You did great. You were 100%. If you don't think that you're going to pass this test, you're wrong. You're going to pass it. You're already doing 100% right now. All right. GI bleeding. GI bleeding. Let's talk about GI bleeding. Now, before we go to the vignettes, let me give you my 30-second lecture that will tell you everything you need to know about the test and life. Are you ready? What does hematemesis mean? Vomiting up blood. What does coffee ground mean? Digested, old blood. Very good. What is melena? Black stool. What is hematochezia? Bright red blood stool. Okay, guys, don't forget that. Now I'm going to ask you questions about this. Listen carefully, okay? All right. We divide up gastrointestinal bleeding into upper tract and lower tract. Upper tract and lower tract. Upper tract is, we don't usually include esophageal varices. That's a separate entity. When we say upper tract, we usually mean stomach and duodenum and lower tract colon. In between, I don't know what you call it. But what you'll be tested on is upper tract and lower tract. So, test question. What are the two most common causes of bleeding in the upper tract? Ulcers and gastritis. Guys, what are the, test question, 3 most common causes of gastritis? Alcohol, aspirin, and NSAIDs. And guys, people still take aspirin, meaning for pain and stuff. They do. All right? Let me ask you a question. If aspirin came out today, would it be a prescription drug? Yes. Yes. Yeah, be a prescription drug. So guys, the two things for bleeding, upper tract bleeding. Oh, why, Zia? Because, Zia, yes, Zia, because of the bleeding. Oh, yes. Zia, why do we normally take aspirin now? I take an aspirin every day. Why do I take an aspirin every day? Yeah, I don't take it for pain. I take it to prevent an MI, to prevent a stroke. And when I go to the dentist, I always tell them I'm on aspirin because when they do my teeth, do I bleed less or more? More. And guys, let me tell you a little story in medicine, okay? I'd rather have someone with a coagulopathy, like an INR that's elevated, than to have bad platelets. Any surgeon will tell you that they'd rather have good platelets than anything else. You got bad platelets, like aspirin does it, and you will bleed. And the reason why aspirin would be most likely a prescription drug is, guys, I know you don't know this, but I've operated on a lot of people from gastritis from aspirin, okay? All right, so the two common causes of bleeding of the upper tract, I want you to use that term, upper tract, peptic ulcer disease and gastritis, okay? The lower tract. We generally talk about the colon as the lower tract. Listen carefully. Test question. The most common cause of bleeding from the lower tract is actually cancer. Because even though you may not be bleeding a lot, you're bleeding. The most common cause, if they get asked this question, the most common cause of bleeding from the lower tract is cancer. Listen carefully. The most common cause of massive lower tract bleed. No, don't say hemorrhoid. Guys, Alicia, that's always a trick question. No. Very good, Tanya, is diverticular disease. The most common cause of massive lower tract bleeding is diverticulosis. By the way, does diverticulosis perforate? Nope. Does diverticulitis bleed? Nope. Okay, just remember that. This is so important, I'm going to repeat it. Lower tract. Lower tract. The most common cause of bleeding is cancer. Even if it's guaiac positive stool, that's bleeding. The most common cause of massive lower tract bleeding is diverticulosis. You with me so far? You with me? Okay. Now listen carefully. Guys, listen to what I'm saying. This is a very important point. Can you get hematemesis from an upper tract bleed? Yes. Can you get coffee ground from an upper tract bleed? Yes. Can you get melena from an upper tract bleed? Yes. Can you get hematochezia from an upper tract bleed? Yes. Can you get melena from a lower tract bleed? Yes. Can you get hematochezia from a lower tract bleed? Yes. And here's the curveball. Can you get hematemesis from a lower tract bleed? No. Guys, the bottom line, what I went through that exercise for, is that you can get everything from everything except backwards. You can't go backwards. You can't go backwards. So, listen carefully. When someone comes in with hematemesis or coffee ground, one of the first things you do is you put in an NG. Test question. Why do you put an NG in the patient? No. Zia, you get the gold star to prevent aspiration. Gold star. If someone has hematemesis, you know they're vomiting from their stomach. The danger is, what happens if they vomit and they pass out? What are they going to do? They're going to do what? Aspirate. Guys, the reason you put in an NG in a patient who has hematemesis is to prevent aspiration. Okay, listen carefully. Guys, you got to listen carefully because this is kind of complex. The next step is endoscopy. And the reason you do endoscopy, listen carefully, is to determine diagnosis. Let me explain why that's so important. Because you want to know diagnosis. Why? Well, if you've got a bleeding ulcer, and let's say the endoscopist doesn't do interventional endoscopy, okay? All they do is diagnosis. If you've got a bleeding ulcer, and it stops bleeding, and 2 days later it rebleeds, and you got to operate, is that a big operation or a small operation, over sewing that ulcer, generally speaking? That's a small operation. It's not a big deal. Okay? Let's say you have a gastritis, guys. Generally speaking, is a gastritis diffuse or local? It's what? It's usually diffuse. If you operate on a gastritis, what operation would you have to do? What would you have to take out? A gastrectomy. Big or small operation? Big or small morbidity? Big or small mortality? Guys, so listen carefully. The answer to the question you want answered for upper tract bleeding is diagnosis. Why? Let me explain. It sets your posture. Meaning, if I know there's a bleeding ulcer, and 2 days later he bleeds, I don't think much about operating, opening the stomach, and oversewing it. It's a small operation. If that guy has a gastritis, I will sit on that patient forever. Because most gastritis stop bleeding. Because if I go in and operate, what must I have to do? A gastrectomy. And guys, I have tried to do a near total or a subtotal gastrectomy for gastritis, and you know what happens? The piece that I leave in, bleeds, and I got to reoperate. Does everyone understand this? That the question you want to ask on upper tract bleeding is diagnosis, because it sets your posture. You're going to sit on a gastritis. You're not going to operate unless you have nothing else you could do on a gastritis, because you will have to take out the entire stomach or most of it. Does everyone understand that? Okay, now listen carefully, guys. If you have a lower tract bleed, and you don't know where the bleeding is coming from, we're not talking about a cancer, we're talking about divertic. The most important question you want answered is location. Because if you don't know where that bleeding is coming from, what operation must you do? A total colectomy. Big or small operation? Big or small morbidity? Okay. Is a hemicolectomy tolerated much better? Yes. So the question you want answered in lower tract bleeding is location. Test question. What are the two ways that you can determine location, and they'll never make you pick between these, on a lower tract bleed? Guys, stop for a second. Colonoscopy, you will always say, and it's correct on the test to say to do a colonoscopy. And do you know what colonoscopists say after they do the colonoscopy? They say, Mark, all I saw was what? All I saw was blood. And is it dangerous in a way to do a colonoscopy on an unprepped patient who could have a cancer? Yes. Could you perforate? Yes. So there are better tests. And the two tests are very good, so not very good. A red blood cell scan, a tagged red cell scan, or an arteriogram. Can I explain to you both so you understand it? Okay. A tagged red cell scan is a nuclear medicine scan. They take out some of your own blood, they tag it with technetium, which is a radioactive stuff. They inject it back into you, and they use a fancy Geiger counter, and they can tell whether you're bleeding from the right colon, the transverse colon, or the left colon. That's called a tagged red blood cell scan. The other test is an angiogram, where they just look for the bleeding sort. You will never have to choose between the two, because some places do a better nuclear scan, some places do a better angiogram. But the question you want answered is location. Now, someone mentioned a barium enema. Listen to me very carefully. No, angio by CT isn't good enough, Justin. It has to be a real angiogram. Guys, listen to me carefully. This is a test question. You were all taught that barium enemas can sometimes be therapeutic for diverticular disease. Right? You were taught that. Okay. So let's say, I'm just going to say, we had a lower tract bleeder, we do a barium enema, and we see diverticularly on the right side or the left side. So we got diverticularly all over. And it doesn't stop the bleeding. Okay. So then we ask our angiographer to do an angiogram to see where the bleeding is coming from. and the angiographer takes a plain film of the abdomen and says, Mark, sorry, I can't do an angiogram because there is, Alicia, what did you say? What did you say? You're correct. There's barium in the diverticulae. A barium enema is contraindicated in the face of lower tract bleeding. I'm going to repeat this whole thing because it's so easy but so important. Upper tract bleeding. The question you want answered is diagnosis. It sets your posture, whether you're going to sit on the patient forever or operate. Lower tract bleeding. The question you want answered is location, because you'd rather take out half of the colon than the whole colon. Next question. If someone comes in with melena or hematochezia, can it be lower tract? Yes. Can it be upper tract? Yes. Okay, so that patient comes in with melena or hematochezia. How do you determine if it's upper tract? NG tube. You put, guys, test question. Every patient who comes in with hematochezia or melena, you stick an NG in. Why? To make sure their bleeding isn't coming from upper tract. How embarrassing. You work them up for a lower tract bleed, and you find out it's an upper tract bleed. Does everyone understand that? You're going to get someone to say, hey, why are you putting an NG in me? And you explain, because I got to make sure you're not bleeding from the upper tract. Do you understand that? Does everyone understand that? All right. Very, very important. Upper tract bleeding, the question you want answered is diagnosis. Lower tract bleeding, the question you want answered is location. And when a melena or hematochezia comes in, you stick an NG in to make sure they're not bleeding from above. One more question. Do you need the room number in the ICU when someone has melena? Do you need the room number? Or can you find that patient from another way? This is kind of a little bit of a... Right, Jim. The smell. Has anyone ever smelled melena? It has a very, very distinctive odor. And guys, if you get called to the ICU for a lower tract bleeder, you won't have to get the room number. You will. I'm serious. It's so pungent that you will go right to the room. Has anyone smelled it? Tell me, please. Have you smelled it? Okay. You remember the smell. It's a very pungent odor. All right. Now you know everything there is for the test and in life. Let's go through this scenario. Number 28. A guy has hematemesis. You stick in an NG. Why? Why? To prevent what? Aspiration. And you'd scope the patient. Number 29. A guy has 3 large bowel movements that are dark red blood. What would you stick in first? An NG to make sure it's not upper tract bleeding. Number 30, same thing, an NG, bright red blood. You'd scope the patient to determine the diagnosis. Number 31, you got a guy who has dark red blood in their poopy, okay? And an NG is normal. Therefore, that patient is a lower tract bleed. And you would do either an angiogram or a red blood cell scan. So guys, in your brain, I want you to think of GI bleeding in terms of upper tract and lower tract. Do you understand that? Just like when we talked about obstruction, you thought about small bowel and large bowel. On GI bleeding, I want you in your brain immediately when you're walking to the patient. Upper tract, is this upper tract bleeding or lower tract? Because is the treatment entirely different? Yes. Does everyone understand that? Very, very, very good. Is this that difficult? Come on. Is this that difficult? All right. Now, number 33 is the one curveball. Listen to me. Thank you, Alicia. It's very nice of you. Number 33. You got a kid who comes in with a bloody bowel movement. Guys, you do not do all this with a kid. A kid doesn't have an ulcer. A kid doesn't have a gastritis. A kid doesn't have cancer. And a kid doesn't have diverticular disease. Very good. Yusra, a kid has a Meckel's diverticulum. Test question. So if you get a kid and they say the kid has hematochezia, you do what's called a Meckel scan. Do you guys know what a Meckel scan is? It's a nuclear medicine scan that shows you either gastric mucosa or pancreatic mucosa in the Meckels. Very good. Guys, all they want to know is make sure you're thinking correctly. You do not scope a kid, generally speaking. All right? Now, 34. 34 talks about a stress ulcer. Guys, it is so uncommon now. Do you know what? Years ago, when I was your age, stress ulcers were incredibly common. But nowadays, in the ICU, what do you put? PPI. Okay, you put people on prophylactic PPIs. The nurses check the pH of the NG tube. You give them antacids. Stress ulcers are not close to be the way they used to be. So I just want you to know that because of good nursing care, it's very, very uncommon to get a stress ulcer. All right? Okay. So that's GI bleeding. Tell me something. Is it that hard? Is it that hard? No. But in your brain, upper tract, lower tract. Upper tract, lower tract. That's how I want you to think about it. Don't forget it. Okay. Next, we get an acute abdomen. All right? How would you define in your brain conceptually an acute abdomen? I mean, in your brain, what would you think of? What would you say? Painful, very good. I want you to give rigid, okay, guardian, okay. Guys, can I give you something in your brain to remember? An acute abdomen? An acute abdomen is an intra-abdominal catastrophe. Guys, in your brain, memorize that. An acute abdomen is an intra-abdominal catastrophe. Why is that so important? Because, guys, if I'm your attending and you call me up and you got a patient who has an acute abdomen, I don't want you to tell me anything but just that. You call me up and you say, Professor, patient has an acute abdomen. It immediately tells me that we have an intra-abdominal catastrophe. So you got number 35. A guy comes in and has an acute abdomen, and it started like that. Just like that. What's the most likely cause of someone would have an acute abdomen just like that? Whoops, I said it. A perforated ulcer. A perforated ulcer. Have you ever seen a perforated ulcer? It's very dramatic. The patients will look prostrate. They will look prostrate. And it's not a bleeder. Very good, Celeste. You get the gold star. It's not a bleeder. Thank you. Guys, test question. Test question. What is the best plain film for free air? The best plain film. The best. Test question. Erect chest x-ray. Erect chest x-ray. You're looking for air underneath the what? Diaphragm. Very good. If the guy can't get erect, then what is your second best test for free air? I love, Ugandera, what you said, and Emanata, what you said too. Everyone always says lateral decubitus, but which lateral decubitus? And they'll test you. It's left lateral decubitus, because you're looking for air above the no, not above the liver. Guys, that's a test question. Let me say it again. Best test, plain film, free air, or erect chest x-ray. If the guy can't get erect, then the second best test is a left lateral decubitus, looking for air above the liver. Okay? All right. And what do you have to do if you got a perforated ulcer? They will go into multi-system organ failure and die if you don't. Guys, who was the one who mentioned Eric Clapton? That they liked Eric Clapton? Who? Okay. Claudia, you did? Okay. Guys, do you know Eric Clapton used to do what? Drink an awful lot. Many years ago, he perforated an ulcer on stage at the University of Minnesota. Now, guys, you said, Amanat, if you had a perforated ulcer without symptoms, all I can tell you is that is bizarre. So I would take that out of your memory. Why? Because when you hear hoofbeats, you don't think of zebras, and that is a zebra. Okay? Most people with a perforated ulcer look like they look prostrate. I don't know how else to say it. They look prostrate. Okay? And you go in and you sew up that ulcer. Now, do you see question number 36? Do you see number 36 on your book? Would you please take a black pen and X it out? I don't ever want you to look at it. It's very, very rare, and I don't want you, it's called primary peritonitis. You're not going to be tested on this on step 2. Would you please X it out? Okay? All right. I don't want you to look at it. Number 37, a guy comes in motionless, and he's got a perforated ulcer. Guys, let me ask you a question. If you don't see free air, would you get a CAT scan? Yes. Yes, yes, yes. Because sometimes the perforation, instead of going anterior, is posterior, and you'll see air posteriorly. So guys, you don't always have to get a CAT scan, but sometimes you do. Sometimes you do. Most of the time you don't. Oh, I want to ask you another question. Have you ever heard of a board-like abdomen? Do you have to be Arnold Schwarzenegger to get a board-like abdomen, as hard as a rock? No. A 90-year-old person. Have you ever felt a board-like abdomen? Has anyone ever felt it? It feels like a board. It does not feel like a human. It is unbelievable. Zia, it's like you said, very hard. It doesn't feel human. And if you've ever had the chance to feel a board-like abdomen, it's incredible. You can't believe that it's a human. Now, listen to me carefully. Number 38, you got an alcoholic who comes in and they have an acute abdomen. Okay? Wait, Claudia, you know what the mechanism is. You get irritation of the parietal peritoneum, and the parietal peritoneum causes the rectus muscle to go into spasm. Have you ever gotten a Charlie horse? Do you guys know what a Charlie horse is? You know what a Charlie horse is? You get a cramp in your leg when you're sleeping. That's unbelievable. And you feel your leg, and that muscle feels like it's a rock. Guys, think of a board-like abdomen as a Charlie horse in your belly. Unbelievable. 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 Yeah, while swimming, stuff like that. Yeah. Okay, that's what it feels like. Okay, listen carefully. I was bringing up a real important point. You got a guy who's an alcoholic who comes in with an acute abdomen. Listen to me carefully. Could they have a perforated ulcer? Absolutely. But let's say your amylase and lipase are off the wall and you don't see free air. It's pancreatitis. Pancreatitis can cause an acute abdomen. Do you operate on an acute abdomen from pancreatitis? No. No. I'm going to ask you a very difficult question now, but I have faith that you'll know how to answer it correctly. It's actually a step 3 question. You got a patient who comes in with an acute abdomen. There's no definite free air. The amylase and lipase are a little bit elevated, but not gigantically. The CAT scan, it's unclear. There may be free air, but it may just be a swollen pancreas. You're on the fence, and you don't know. You got this acute abdomen. So the question is, are you going to operate or not? What are you going to do? You guys all get the gold star. Why are you operating? One word. Safety. No one will argue with you guys. Opening up a patient, you'll see pancreatitis, you close them up. You sit on a patient who has a perforated ulcer, and they will go into multi-system organ failure and die. And guys, I'm so proud of you that that's not an easy question. And it's not on step 2, it's on step 3. But guys, just like I told you, if you are on the fence and you're thinking, well, you know, what should I do? It's safer to operate. So now I'm going to ask you another question. Listen carefully. Is it harder to operate or harder not to operate? Very good. It's harder not to operate by far. If you're going to operate, you're going to operate. You're going to see with your eyes. You're not going to operate. You wonder, should I be in that patient's belly? Very good. You guys impressed me very, very well. Look at number 39. A patient has right upper quadrant pain and has vomiting and they get sick with eating McDonald's. What do they likely have? Acute cholecystitis. Very good. And that can cause an acute abdomen. We admit that patient to the house, and we cool them down a day or so, and do what? What do we do? Very good, where they do a cholecystectomy. Number 40. You got a patient who has colicky right flank pain, and it radiates to their scrotum, and they have microscopic hematuria. What do they have? Ureteral colic. Is that a lot of pain or not a lot of pain? Unbelievable. And you make the diagnosis by CAT scan, and usually they will need a procedure to get the stone out. Oh, Alicia, with due respect to the women, they say that a ureteral stone is the worst of any pain. Have you guys ever seen a patient with ureteral stone? The amount of morphine they will require is unbelievable. If you give yourself that amount of morphine, you'd stop breathing. That's how much it is. Jeremiah, you had it. How bad was it? Very bad. Okay. Number 41. You have a guy who has left lower quadrant acute abdomen, and it's happened multiple times in the past. What is the likely diagnosis? Diverticulitis. Common? You bet. You bet. You bet. All right. Now, listen very carefully, guys. Number 42 is a mistake. It shouldn't be put here. So I'm going to help you with this. Listen carefully. Number 42 is a patient who has a volvulus. And as you know, a volvulus is the second most common cause of large bowel obstruction. Very, very good. In of itself, listen carefully, guys. Celeste, excellent. Obstruction. Guys, listen carefully. Would a bowel obstruction in of itself, cause an acute abdomen? In of itself? No. No. Unless the obstruction of the volvulus made the bowel, very good, Justin, die. Strangulate. So guys, number 42, I want you to write this on the side of 42. You're not operating on this patient for a volvulus. You're operating for dead gut. Does everyone understand that? When you have an obstruction, you don't have an acute abdomen. When you have a volvulus and that patient has an acute abdomen, you're operating not for the volvulus. You're operating for what? Dead gut. Does everyone understand that? The reason I say that is 42 should not have been put in here. 42 is a cause for large bowel obstruction. But I'm going to make it fit in by saying you sat on the patient too long. Instead of trying to decompress their volvulus, you sat on them, and they turned into what? Dead gut. Does everyone understand that? That's so important. I'm going to say it again. Any bowel obstruction, especially a volvulus, if you don't do nothing about, what's going to happen to their bowel? It's going to what? Infarct, and therefore imperforate, and therefore, what physical exam will you have? An acute abdomen. Does everyone understand this? You see, when someone has an obstruction, they may have pain, but do they have an acute abdomen? No. No, no, no. No, 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 no. But when someone has an acute abdomen and they started out with an obstruction, baby, you waited too long. And you've got a strangulated obstruction, and now you've got dead gut. Does everyone understand this? All right. That's correct, Isri. You operate to prevent an acute abdomen. Remember I told you, the rule that I live by personally and professionally, it's better to stay out of trouble than to get out of trouble. Oh, absolutely. Better be safe than sorry. Absolutely, guys. I'm telling you, you don't. And how successful is colonoscopy for volvulus? Incredible. The vast majority, vast majority of volvulus is treated by colonoscopy. 9%. Oh, yeah. It's only when the nursing home who sends the patient over a week later, and then they have an acute abdomen. And would you get a CAT scan on a patient who has a diffuse acute abdomen? No. What are you going to do? What are you going to do? You're going to operate. All right. Very good. This was a hard one. This was a hard one. All right. Now, number 43. A guy has atrial fibrillation, guys. And they come in and they have a very, very tender abdomen. When anyone has atrial fibrillation and they come in with a tender abdomen, what disease do you think about? Mesenteric ischemia and infarction. Very, very good. And usually, if the patient doesn't have an acute abdomen, meaning the pain is out of proportion to the physical exam, you hydrate them. And you put them on bowel rest and they get better. But if they develop an acute abdomen, why are you operating? For what? Dead gut. That's so important. I'm going to say it again. You guys are right on belly pain from mesenteric ischemia. And they don't have an acute abdomen. Their pain is out of proportion to their physical exam. You put them on bowel rest and you hydrate them. And most of the time they get better because there's lots of collateral circulation in the gut. But in doing so, if they develop an acute abdomen, why are you operating? Why? Dead gut. Let me tell you a story, guys. About a month ago, there was a 92-year-old woman who was in renal failure and came in with advanced myocardial ischemia where she had an acute abdomen. And her CAT scan, which they took, showed that her small bowel and large bowel was dead. I mean, it was just dead. Patient was alive. Unbelievable. She was on dialysis for renal failure. Let me ask you a question. This is a hard question. The family came in, lovely family, and they said, Dr. Hill, should you operate or not? Let me say it again. 92 years old, in renal failure on chronic dialysis, CAT scan shows dead small bowel, large bowel. Should I operate or not? You are all correct. Not operate. Because if I operated, first of all, the patient would die in the operating room. That's correct. Alicia, no matter what I did, they die from anesthesia. But if I opened up this 92-year-old, I'd have to take out their small bowel and large bowel. The patient would have to live on total parenteral nutrition. Well, if this was your mother, what would you do? Would you want me to operate or not operate? Very good. I like the Latin. Not operate. But I had to talk to the family, and we made her comfortable. And Arlene, exactly what you said. Leave her in peace. We gave her tons of morphine, and she was comfortable. But you're correct. If I was a cowboy, do you know what a cowboy is? Remember I told you what a cowboy is? Guys, you know what a cowboy is? I would have said, yeah, acute abdomen, you know, a chance to cut is a chance to cure. Take her to the OR, and she would have died on the table. And it would have been very, I like that, Z, a reckless hero. I like that expression. You're correct. You guys are thinking absolutely perfectly. Absolutely perfectly. Seriously, very good. Okay, you guys are very, very sharp today. Perfect, absolutely perfect. Okay, let's take a break, get something to eat, and I'll see you shortly. All righty. All right. Okay. Alrighty. Are you all there? Are you there? You guys sure did well in this first hour. Very impressive. You guys are very, very sharp. Tell me what you did in this 10 minutes. What did you do? You slept. Arlene, how could you sleep for 10 minutes? I don't know how you could sit. Relax. A cat nap. Made coffee. Made a smoothie. Oh, Alicia, I'd like what? Eating, what is a tostoni? You're going to make tea? Monster? What? Ah, Justin, don't drink that stuff. Don't drink that stuff. It's not good for you. Eating chocolates. I like that. Checked on the baby. I like Celeste. Ah, that's nice. Checked on the baby. How is the baby, Celeste? Mark, you ate chocolate too. Good for you. How old is the baby, Celeste? Ah, napping with Daddy. Oh, 5 months. Oh, I miss those days. Coconut water. I've never had coconut water. You guys, I will try it, Arturo. I wish I could see your faces. I mean it. I hate this about this. I hate not seeing your faces. I wish. Yes. Nimrita, yes. You are so. Yes, I try to get to know you. It is true. And yes, it really does help with the learning. And yes, you will pass step 2. And yeah, it would be nice to see everyone. Before I forget, can I give you my email? Because the last online class, I asked everyone to send me their picture. Seriously, I asked everyone to send me. So, you ready? Okay. D as in dog, R. Someone, when I finish it, write it out. D as in dog, R, 1900, 210, MD at AOL.com. Write it out and I'll tell you if it's correct. DR 1900, 210, MD. That's it. Okay. You got it. You got it. AOL. Yes, AOL. My kids say, oh, why do you have AOL? I know. I know. You can always tell the age of the person if they have AOL. My kids have, everyone has Gmail and stuff like that. I'm sure none of you guys have AOL. And look at this. Do you know what kind of phone this is? A BlackBerry. I'll bet you none of you have BlackBerries. See? You still have your Hotmail. Okay. Yes, I am a dinosaur, Jose. You don't have to rub it in. Alicia, I know. Ha, 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 ha. Okay. All right. All right. Okay. Hepatobiliary, guys. All right. Liver. If someone has a mass in their liver and they have an elevated alpha-fetoprotein, what is that mass? Hepatocellular cancer. Hepatoma, correct. Hepatocellular cancer. If that same person, number 45, has a mass but has an elevated CEA, what is that mass? Metastatic. Okay, no, you can't say pancreatic. It's metastatic. It's metastatic. Okay, alpha-fetoprotein, primary. Hepatocellular cancer, CEA, metastatic. Very, very good. 46. A woman comes in, a young woman comes in, and they are in shock. No trauma. They got an acute abdomen, in shock, distended abdomen. Where are you going? Where are you going with this patient? To the OR. You have no idea what's going on. You do a fast scan, maybe, and you'd see blood everywhere. Okay? You have no idea. Correct. You'd go to the OR, and why would you go to the OR first? Why? One word? Safe. And you open her up, and the patient has a ruptured hepatic adenoma. Ruptured hepatic adenoma. And what was she taking? Birth control pills. Okay, so you take out the adenoma, you save her life, and the patient post-op says to you, Dr. Hill, can I go back on birth control pills? What do you say? Never. Thank you. Never, never, ever. Guys, you never make the diagnosis of a ruptured hepatic adenoma pre-op. Ever, 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 ever. Ever. The patient comes in dying. You open them up and you find it, okay? Never can they go on birth control pills. Has anyone ever seen a ruptured hepatic adenoma? It's not common. It's not common. All right, you make it after the fact, guys. No one will ever make it pre-op. If they tell you they made it pre-op, they're lying, okay? Because you're operating because you're safe, and you open up the patient and you see what they're bleeding from. All right. Number 47. Listen carefully, guys. A guy has choledocholithiasis, which means that they have Charcot's triad. What is Charcot's triad? Come on. Fever, pain, jaundice. Very good. Is that good or bad? Bad. Ascending cholangitis. And they come in with a right upper quadrant tenderness, and you get an ultrasound, and it shows a liver abscess. How would you treat that pyogenic liver? Drain it. Very good. Either operatively or percutaneously. Either way. Okay. Number 48. You get a guy from Mexico who has fever, white count, tenderness in the right upper quadrant, and an ultrasound shows an abscess. Would drainage be your first step or not? Correct. No. Because this could be what kind of abscess? Amoebic. Amoebic. And do you want to spill all that junk inside the belly? No. And you would treat this patient how? How? Metronidazole, Flagyl. And guys, many times this goes away. But here's your test question. Listen carefully. You got a patient who's a migrant worker from Mexico. They have a liver abscess. You treat them. You say, I'm going to treat you with antibiotics. And every day in the house, they're getting worse and worse and worse. Would you continue the antibiotics or would you operate? Very good. And why would you operate? One reason. Safe. Very good. Guys, if the metronidazole isn't working, you don't continue it. You don't let someone die. Do you understand that? I will tell you that a lot of the time, if it's an amoebic abscess, it'll go away. But I'm telling you, you don't sleep well at night. Listen carefully. When the nurse calls you up in the middle of the night on this patient that you have on Flagyl and says, Dr. Hill, the temperature is 103. What's going through your brain is maybe I should have operated on this patient, because I will ask you this again. Is it harder to operate or harder not to operate? Not to. Oh, you guys are perfect. Very good. Perfect, perfect, perfect. All right. Has anyone ever seen an amoebic abscess? Has anyone ever seen it? Yeah. It's not rare. It happens. Okay. Number 49, 50, and 51. Sorry, we're talking about jaundice. Number 49 is when someone has all indirect bilirubin. What kind of jaundice is that? Hemolytic, very good. Could you name a hemolytic anemia, please? Come on. Sickle cell, very good. Okay, G6PD. Okay, very good, very good. Okay, all right, very good. That's not a surgical jaundice. Number 50. A patient went to Cancun. Their transaminases are off the wall, and they have mixed jaundice, direct and indirect. What kind of jaundice is this? Hepatitis, hepatocellular jaundice. Again, not surgical. Very good, viral hepatitis. Now we get to 51. A patient has an elevated ALK Phos. Guys, listen to what I'm saying. An elevated ALK Phos, and their direct bilirubin is off the wall. What kind of obstructive jaundice? That's surgical jaundice. Obstructive jaundice. You can tell by the direct bilirubin high and ALK Phos. Guys, those are the two numbers we always look at. The ALK Phos and direct bilirubin. Okay. Now, 52. You got a woman who every time she goes to Burger King, she gets pain in the right upper quadrant, and all of a sudden she becomes jaundiced, and her eyes become yellow, and her alkaline phosphatase is off the wall. What does she have? Choledocholithiasis. Guys, say choledocholithiasis. She has choledocholithiasis, Charcot's triad. Okay? Now, in that situation, how would you get rid of the choledocholithiasis? ERCP, and they do an ERCP and they get rid of the stones. Now listen carefully, okay? The next number of vignettes are very confusing, and I'm going to make it very easy for you. Listen carefully. When someone comes in with obstructive jaundice, common things happen commonly. By far, the most common reason for obstructive jaundice is stones, choledocholithiasis. And you tell that by what imaging test? What imaging test? Ultrasound, right, okay. Listen carefully, listen carefully. If they don't have stones, but have a dilated duct, it's one of three diagnoses, and they're all cancers, and they're all terrible. Listen carefully. It's either cholangiocarcinoma, ampullary carcinoma, or carcinoma of the head of the pancreas. Let me repeat that. This is so easy, and everyone gets confused. Common things happen commonly. You got a patient who comes in with obstructive jaundice, elevated ALK Phos, and elevated bili. The first test you do is ultrasound because common things happen commonly. And you look for what? Stones. If you don't find stones and you have a dilated duct, there are three diagnoses that can cause this. Cholangiocarcinoma, ampullary carcinoma, or head of the pancreas part carcinoma. And they are all dealt with exactly the same way. You do an ERCP, you do a CAT scan, and you do an endoscopic ultrasound. And after that, you might operate. We used to operate all the time on things like this. Nowadays, we're not too keen on operating because they end up dying. Do you understand? It's so easy. You look for stones. If there's no, right, a Whipple. If there's no stones, it's one of three diagnoses: cholangiocarcinoma, ampullary carcinoma, head of the pancreas. They're treated the same way: ERCP, CAT scan, endoscopic ultrasound. Okay? Now, test question, guys. Test question. On any one of these patients who have cholangiocarcinoma, ampullary, head of the pancreas, you feel a mass in their abdomen. What is that mass? Test question. Yusra, you get the Zia, you get the gold. All of you guys get the gold star. An enlarged gallbladder. But please, guys, en français. A Courvoisier gallbladder. Very good, Claudia. A Courvoisier gallbladder. Be classy. Yeah, it's a distended gallbladder, but be classy. When your professor asks you, what is that mass, you say, no, it's not a porcelain gallbladder. That is not correct. It is not a porcelain gallbladder. It's a Courvoisier gallbladder. A porcelain gallbladder is seen in chronic cholecystitis. It is not a porcelain gallbladder. Courvoisier gallbladder. A Courvoisier gallbladder. It's a thinned out big gallbladder. Okay, Amina? Do not confuse that. It's not a porcelain gallbladder, okay? It's a Courvoisier thin wall gallbladder. Very good. Okay. So now, when we get to number 57, we have a woman who comes in with right upper quadrant pain after she eats a Big Mac, and you got gallstones. Guys, that is biliary colic. You know what that is. That patient needs what? What does that patient need? Nothing. Zia, wait, stop for a second. Zia, are you going to just send that patient and say you don't need anything? Of course, they need an ultrasound. And they need a cholecystectomy. Come on now. Number 58. You got that same patient who has a fever and a white count. That patient has acute cholecystitis. You treat him the same way. You'd cool him down and operate on him. Zia, you wouldn't sit on a patient who's got biliary colic who's getting worse and worse, would you? Is that safe? Of course not. Zia, you don't have to apologize. You're very polite. But it's not safe. What would you tell that patient? You would say, you got to get your gallbladder out. Okay? All right. Very good, Zia. Okay, good. Now, guys, number 59 is one of, generally you operate on the same admission. The same admission. Can I tell you what we used to do? Listen for a second, guys. We used to wait 6 weeks. Yes, always laparoscopy. We used to wait 6 weeks. Do you know why? We would let the swelling go down. Swelling go down, okay? We don't do that anymore. We do it the first admission. If they're asymptomatic, they never came to you. Daniel, if they're asymptomatic, they never came to you. If you had asymptomatic gallstones, they wouldn't come to you. You wouldn't see them. The patient is asymptomatic. If they come for other reasons and they have stones, on ultrasound, you do not take it up. You do not do a cholecystectomy. You do not. We used to. We don't do that anymore. Only if they have symptoms. Period. Okay? Understand? Now, guys, well, Daniel, they do things in different countries differently. Okay? And it's not because of laparoscopy. It's just, I'll give you an example, okay? My son is a professor in England. Now, in England, as the word can tell you, that they treat acute appendicitis. How? How do they treat acute appendicitis in England? No, not in England. If they have a ruptured appendix, they operate. Well, expected, not quite. They treat conservatively with antibiotics. And they will only do an appendectomy if the patient has a ruptured appendix or an acute abdomen. I tell my, and again, they have good literature. Guys, they have good literature. No, Justin, they're not crazy. They have good literature. But we in the United States, and for your test, we operate. And I tell my son, I say, seriously, I say, Adam, if you ever get pain on the right side, he's a physicist, he's not a MD. I say, you get on a plane and you get back home to America, because I would never allow it with antibiotics for an appendicitis, because I wouldn't want him accidentally to rupture and then die. But I want you to understand there's different ways of doing it. If you go to England, they have literature that shows it, just like in Colombia. So, Justin, you can't say that someone's crazy. It's a different way of approaching it. You know what I mean? A different way of approaching it. Yes, the person is managed in the house on antibiotics. That's correct. And they have papers that in a patient who is not ruptured, does not have a abscess, that does not have an acute abdomen, that they do okay. Guys, in the United States, we have a lot of trouble with that. Now, David, in Canada, don't you guys sometimes treat appendicitis with antibiotics? No? Okay. I thought some places in Canada do that, follow that. But guys, the bottom line is just a different approach. That's all. It's a different approach. Now, listen to me, guys. I want to get to 59 because it's a really important question. Remember we talked about a patient with Charcot's triad, choledocholithiasis, pain, fever, jaundice. Okay? All right? But the nurse calls you up and says, the patient looks like they're going to die. Meaning, their temperature is 105 and they have chills. Guys, you have to do an ERCP right then. If you don't decompress that duct, they prostrate. Yes, they will be prostrate. They will die of multisystem organ failure. So guys, this is one of the first test questions that you will be asked. You will listen carefully. They will present a patient with Charcot's triad. And usually in Charcot's triad, the next day you could do an ERCP, put them on antibiotics. But they will present a patient with Charcot's triad who has a fever of 105, chills, hypotension, and the nurse calls you and says, I think this patient is going to die. You call up the ERCP person and you get them to do this now. Do you understand that? It's a small percentage of patients who get this, but you can't sit on it. When a patient looks like they're going to die and looks prostrate, you've got to decompress their duct. Okay, immediately, emergently. All right, very, very good. Now, if you look at number 60, here's a patient who has gallstones, and all of a sudden, they get pancreatitis. Can gallstones cause pancreatitis? Yes. Tell me the other cause of pancreatitis. Alcohol, by far. The two most common causes of pancreatitis are alcohol and gallstones, by far. So if you look at 61, you've got a patient who has pancreatitis, okay? Test question. Test question. Is there a cure for pancreatitis? No. Therefore, what is the treatment of pancreatitis? Diamond, 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 you get the gold star. Let me explain, guys. Guys, listen. Stop. Diamond said the word I wanted. Remember when I told you when someone had atelectasis, what do? You call it pulmonary toilet, and the four things of pulmonary toilet are turn, cough, and deep breathe, ambulate, chest physiotherapy, intensive spirometry, and ultrasonic neb, right? You're all correct that the treatment of pancreatitis, IV fluids, NPO, etc., etc., etc. But the word you use, and Diamond did it great, is supportive treatment. So, Zia, you said it correct too. Oh, Amina, you said it too. I want you to memorize that word. Supportive treatment. If I ask you, what are you doing for this patient with acute pancreatitis? You would say supportive treatment. And then if I said, what are you specifically doing? You'd say IVs, NPO, NG, antibiotics, etc., etc. Does everyone understand the word I want you to use is supportive? Not conservative, supportive. Because that's what you're doing, supporting the patient. Very, very good. I'm very impressed that you know that word. I love that. Supportive. Don't forget. Supportive. Okay. All right. Now, number 62. You got a patient with pancreatitis, and all of a sudden their blood count is going down, and they have Cullen sign and Gray-Turner sign. What is the diagnosis? Hemorrhagic pancreatitis. Cullen sign is where? Where in the body? No. Umbilicus, very good. And where is Gray-Turner sign? Flank. Cullen sign is periumbilical ecchymosis, and flank is Gray-Turner. Don't forget it. You'll be tested on it. Okay, you treat a hemorrhagic pancreatitis supportively. Test question. If you can't stop the bleeding, do you know what you do? You don't operate. If you try to operate on a hemorrhagic pancreatitis, you'll end up taking out the whole pancreas and the patient will die. Do you know who you call for hemorrhagic pancreatitis? Interventional radiology. Not the dietitian, Arlene. The interventional radiologist. And they do arterial embolization. Guys, this is very, very important. If you operate on a patient with hemorrhagic pancreatitis, they'll usually die. You call up the interventional radiologist and you do arterial angiographic embolization. Let's take the next question, number 63. A guy's got pancreatitis, and all of a sudden they look septic. They look septic. Again, a great word, septic. What is the diagnosis? An abscess. You make the diagnosis by CAT scan. The patients present septic. The treatment of a pancreatic abscess is drain it. Do you drain it to the outside world or inside the belly? Outside. Very good. You got pus and dead tissue. Do you know what instrument you use when you drain a pancreatic abscess? Your hand. You're scooping out chunky soup. It's not like pus, like a nice little drain. Yes, you put in 1,000,000 drains, but the drainage is you open up the patient and you scoop out chunks of pancreas. Has anyone ever seen a pancreatic abscess? Patients usually die. They usually die. Okay, let's continue. As you can say, I always tell my residents and my students that the pancreas is not your friend. So another complication that the pancreas can cause you is all of a sudden a patient 5 weeks, 6 weeks after a bout of acute pancreatitis gets a big mass in their abdomen. A big mass. They're not infected. They're not septic. They just have this big mass. Pseudocyst. Test question. Why do they call it a pseudocyst? Test question. Very good, Diva. You said it exactly. It is not lined by epithelium. Very, very good. It's really not a, it's like scar tissue. It's not lined by epithelium. Okay? You're very welcome, Diva. You make, necrotizing pancreatitis is pancreatic abscess. That's what necrotizing pancreatitis is. Guys, a pseudocyst. You make a diagnosis by CAT scan. How do you treat a pseudocyst? You have a symptomatic pseudocyst. You drain it. Do you drain a pseudocyst to the outside world, or do you drain it to the inside organs? Inside. Listen to me carefully. If you drain a pancreatic pseudocyst to the outside world, you will get a pancreatic fistula. And I remember every patient I have had with a pancreatic fistula. Do you know why? Because it takes forever to close. You drain a pseudocyst to the organ in which it is contiguous with. There are 3 organs that it can be contiguous with. The stomach, a cyst gastrostomy, the duodenum, a cyst duodenostomy, or the jejunum, a cyst jejunostomy. Listen to me carefully. Don't type, listen. When I was your age, I thought of a pseudocyst like a grapefruit. And I wondered, why didn't they just take out the grapefruit? Why didn't they just operate and take it out? Has anyone ever seen a pseudocyst? Let me describe it to you. You are at the beach with your children and you're making a sand castle. You know what a sand castle is, right? The sand is wet, and you put your fist into the sand and you make a cave. That cave is a pseudocyst. When you open up the belly, you don't see a nice little cyst. you see mush. Do you know how you find the cyst? You stick needles in until you get fluid out. You can't excise. You can't excise a pseudocyst. They're caves. They're caves. And you drain them to the organ in which it is contiguous with. One of three organs: stomach, duodenum, jejunum. So as you can see, listen carefully, the pancreas is not your friend. It is an organ that can cause you big problems. Acute pancreatitis, treated supportively. Hemorrhagic pancreatitis, Cullen sign, Gray Turner sign. If they keep bleeding, interventional radiology. Pancreatic abscess, the patient becomes septic, same as necrotizing pancreatitis. You take them to the OR and you drain it externally to the outside world. A pancreatic pseudocyst, called a pseudocyst because it does not have an epithelial lining. Is it a nice little cyst? No, it's a cave. And you treat that by draining it internally to the organ in which it is contiguous with: stomach, duodenum, or jejunum. Does everyone understand what I just said on all of these things? Now, we come to the final aspect of pancreatitis. Contiguous means against. Contiguous means against. This hand is contiguous to this hand. This contiguous. The stomach, if it was a stomach mark, it would be a cyst gastrostomy. If it was the jejunum, it would be a cyst jejunostomy. If it was the duodenum, it would be a cyst duodenostomy. And all you do is you sew it up together. You make an anastomosis. That's all. It's not hard. Now listen to me carefully. On all of these things, all of a sudden, number 66, you got a guy who gets chronic pancreatitis. Common, unbelievably common. Listen carefully. Listen, 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 listen. Oh, Emma, you're exactly right. It does create an internal... Wait, guys, I want you to listen to Emma. It does create an internal fistula. Absolutely. It does. But you know what happens? When you have a pseudocyst connected to the stomach, duodenum, or jejunum, in time, that pseudocyst collapses. You are exactly right, Emma. It is an internal fistula. Exactly right. Very, very good. Very good. Okay. Guys, let's get back to number 66. Chronic pancreatitis. Yes, the patient could have endocrine insufficiency. The patient could have exocrine insufficiency. But the test question and life question is, why will you know this patient's phone number and their address and their first and last name by heart? Why? Why? Pain, 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 pain. They will be asking for narcotics. Guys, the chronic pancreatitic to the surgeon is like the migraine headache to the neurologist, like the low back pain is to the orthopod. Yes, can they have diabetes? Yes, can they have steatorrhea? Yes. But the one thing that they have all the time is pain. And what can you do for it? Nothing. Do you know why we can't do anything? Because most of these patients are alcoholics, and most of them do, what do they continue to do? They continue to drink. Guys, that's why alcoholism is considered a disease. I have these patients come in, and they're the nicest people in the world. And I say to them, you got to stop drinking. You're going to kill yourself. And they look at you and they say, okay, Dr. Hill, I'm going to stop drinking. And then they come in 2 weeks later and they're still drinking. Guys, that's why alcoholism is a disease. And the reason why chronic pancreatitis is something I hate taking care of is you can't fix them. We've tried everything. You can't fix them. They're addicted to narcotics. We've tried operations. We've tried injections. You can't cure them. They have pain all the time. Has anyone ever seen a chronic pancreatitic? Yeah. It's a sad situation. Because usually they're nice people. And they know that they drink. They just can't stop. Let me ask you a question, guys. Hard question. Not as a patient. Have you ever known a relative or a friend who was a true-blown alcoholic? And those of you who know those patients, but not patients, friends or relatives, have you ever tried to talk to them and ask them? They will say to you that they should stop drinking. And do they ever? Right, Eminado, right. They say yes, but they can't. They can't. Guys, it's a terrible, terrible disease. Terrible disease. They really want to, and it's almost impossible. It's not even nearly as close as cigarettes. You know, people say you're addicted to cigarettes. Not even close. Not even close. All right? And even after years in AA, can I tell you something, guys? I have a close friend who was an alcoholic for a long time, and it's been years since he had a drink. He still goes to the AA meetings. I mean, every week. Every week he goes to those meetings religiously. So, it's not a good disease. All right? Okay. Let's continue. So, the bottom line about the pancreas, guys, it's an organ you never want to mess with. It causes unbelievable problems. It's just one of these bad organs. It is. You need it for life, but if it gets infected, inflamed, you are in deep doo-doo. All right. So next, we talk about hernias. Hernias. What are the 2 complications of hernias, guys? Incarceration and strangulation. Test question. Are all incarcerated hernias strangulated? No. Are all strangulated hernias incarcerated? Yes. Very important point. Let's say that again. Not all incarcerated hernias are strangulated, but all strangulated hernias are incarcerated. Okay? Let's look at number 67. Test question. A little kid comes in and has an umbilical hernia. Asymptomatic. How long do you wait until you fix it? How old? 5 years old. 5, Abir. 5. 5 years old. Not 2. That was the teaching years ago. 5 years old. Because why? Most of those hernias will close. Now, if the kid incarcerates or has pain, you're going to operate on the kid. But the vast majority of umbilical hernias by 5 years old, they're done. Okay, number 68. You have someone your age, college kid, young person, resident, who has an asymptomatic hernia. Do you fix it or not? You fix it. You don't let them. If my kids had hernias, if they were asymptomatic, I'd have it fixed. There's no way in the world you're going to let someone go through life with a hernia. Okay? There's no way in the world that you're going to do that. Because what's the danger? What's the danger of what's going to happen? Incarceration, strangulation. Let me tell you a story. On Thursday morning, guys, I am a visiting professor. I told David, I told you this, in Newfoundland, okay, in St. John's, Newfoundland, okay? There is another professor that I always see up there. He comes up there for the meeting, and he's from Toronto, actually, a place called Hamilton, outside of Toronto. Young guy, much younger than me. He, for all the years I've known him, David, for all the years I've known him, he has this intermittently incarcerating groin hernia. It's so loud when he incarcerates and we're standing next to each other, you could hear the Borg Brigmas, the audible bowel sounds. And he has to press on his groin to shove it back in. And I ask him, I don't want to say his name, but I say, why don't you have that fixed? Why don't you have that fixed? You're going to incarcerate. He's a surgeon. Okay? He kept putting it off. Well, I'm meeting him in Newfoundland on Thursday, and he called me up and he said, guess what, Mark? I had it fixed. I said, you're kidding. Why? And you know what he told me? It did what? What did it do? Incarcerate. Guys, again, if you have a young person who has an asymptomatic hernia, you fix it. Do you understand? Do you understand? And yes, you're correct, Mark. That is correct. And you know what hospital that you're thinking about, Mark? The Shouldice Clinic. The Shouldice Clinic. That's correct. Shouldice Clinic. All right. Now look at number 69, guys. There's a guy who has a hernia that goes into his scrotum. Okay? Goes into his scrotum. And it's incarcerated but not strangulated. Should that patient be operated on? Absolutely. Of course. That patient is a setup for a strangulation. I want to tell you a story that shocked me and shocked my students and residents. You ready for this story? 10 years ago, a patient came into my office, a woman, nice woman, and she was wearing, what do you call these dresses that, it's like a tent? It's just like a tent. Like a tent? What is that called? No, not a kangaroo suit. No, not a jumper. A muumuu. That's correct. And I said, man, and I thought she was obese. And I said to her, I said, well, what are you here for? And she said, I have a hernia. And guys, I swear to God, I'm telling you the truth. She lifted up her muumuu. She had a ventral hernia that went below her knees. I am not kidding you. I had to go like, put my jaw back up. And I asked her, I said, ma'am, how long have you had this hernia? And she said, oh, about 25 or 30 years. And guys, I wanted to ask her, why did you have this repair? Because she was not a heavy woman. She was kind of thin, but all those years, and well, I took her to the operating room, and I needed my medical students to lift up. It was unbelievable to lift up this huge hernia while I prepped it. And no, she wasn't scared, Alicia. I think she had a psychiatric problem where she just didn't acknowledge it. And so anyway, I fixed her up, put her back in. She was now a skinny woman. And when I was doing rounds in the hospital, I kind of wanted her to say, "Oh, thanks, Dr. Hill. You know, boy, I'm really good now." But guys, she just didn't get it. Do you know what I mean? She was polite, but she didn't get how seriously ill she was. This was the largest hernia I have ever seen in my life, below the knees. All of her small bowel was in her hernia. Unbelievable. Unbelievable. So the bottom line, guys, is it's better to stay out of trouble than to get out of trouble. And remember that. Do not sit on... Oh, you went to the emergency room with an acute abdomen? You did? Sanjay, that was you? I mean, you personally? Oh my. And how did you do? How did you do? What did they do for you? If I may ask. If we may ask. That's right, Arlene. What did they do? Let's Sonia say. What did they do? Lap surgery. Are you okay? Was it a big hernia or a small hernia? 7 centimeters. That's a sizable hernia. How did you get the hernia, the ventral hernia? No idea. Sanjay, I'll make you bet that when you see patients with hernias, you will probably personally tell them your story. I mean it. You probably will personally tell them your story, and I'll bet you will never sit on a hernia. I'll make sure that you would never sit on a hernia. All right. So guys, the bottom line is this. I want you to understand something. Physicians of years back used to have an expression which drives me crazy. All right? Here's the expression that physicians used to say. Well, if it doesn't bother you, let's not bother it. Does everyone understand that that's stupid? Does everyone understand that is stupid? Okay? There are times as a physician, if you see a hernia, that you have to say, it's better to stay out of trouble than to get out of trouble. And you take care of it when the patient is well, not when they're ill. Does everyone understand that? And that's the bottom line, as being what? What's the word I keep telling you? Safe, 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 safe. Very good. Very good. Very, very good. You guys did very well on this. Okay, let's take a little break. Get some coffee. Drink your Monster thingy or whatever it is. I'll see you in a few minutes. All right. All right. Okay. All righty. Okay, come on, guys. Tell me what you've done. What did you do? Tea. Finish your tea. You spoke to your mom. Very nice, Nicole. Eating, laundry. Boy, Alicia, very good. You did laundry, made tea, and a salad. Pretty good. Played with your daughters, text messages. Hung out with the kids. Very, very nice, Nada. Coffee. Ooh, you're English. Why are you drinking coffee? You should be drinking tea. Helped your aunt in cooking. It's 1 a.m. 1 a.m. Oh, that's right. I tried calling my son, and he didn't answer. He didn't answer. Yep. He should answer his father, don't you think? All right. I think so. Okay. Your kids just came home from school, Mark. Oh, is that nice? Did they give you a big hug and kiss? Yes? Ah, I miss those days. Alrighty. Guys, listen carefully. Listen carefully. And it is the best, Mark. Alright. We're going to talk about diseases of the breast. Guys, no matter what specialty you go into, you got to know this backwards, forwards, and upside down. It's so important, okay? Alright. Listen to me carefully. We're going to go through this, and you're going to know everything you got to know for the test and life about breast. Alright, number one. An 18-year-old comes in and has a rubbery mass. Guys, this is a fibroadenoma. It is benign. It is solid. It is related to hormones. If a kid comes in or anyone comes in with a solid mass, for the test, you are to do an FNA. What does FNA stand for? Fine needle aspiration. Okay? Guys, that's for the test. For the test. Most of the time, what will happen is, in real life, you'll watch it for a month, and the patient or the mother or whatever will say, get it out. I have very rarely ever had a patient who had a breast lump and said, let's keep it in. Okay? Now, it's very important. If it's a fibroadenoma and it feels rubbery, it feels like one of those not a marble, but it feels like a bouncing ball. What are those called? Those little. It feels that way. All right. Number two, if you don't take out this fibroadenoma, number two will happen. You will have a woman come to you who will have a 6-centimeter mass, which a few years ago was this big. It's a benign fibroadenoma, and you take it out, but what are you left with? A deformed breast. And it should have been taken out earlier. Again, one word, safe, to be safe. This was bad management. They sometimes call it a giant juvenile fibroadenoma. Fibroadenomas usually grow. All right? Number three, a woman has a big mass of her breast. And remember, I told you what is the first test for the first thing you do for the examination. What do you do? An FNA. and it comes back a cystosarcoma phalloides. A cystosarcoma phalloides. That is a type of low-grade sarcoma, and you actually can resect it, and the patients do fine. Cystosarcoma phalloides, a low-grade sarcoma. Here is the test question. Cystosarcoma phalloides is associated with a history of fibroadenomas. Meaning, if you look at patients who have cystosarcoma phalloides, many of them have fibroadenomas at youth. We don't know the relationship, but it exists. And you remove fibroadenomas, and you remove cystosarcoma phalloides. All right? You don't leave them in. Now, number 4. Here's the one that is real common. You get a woman who comes in, and she's got a cyst that gets big, then small, then big, then small, and that is called what? Fibrocystic disease. Is it common? Unbelievable. All right? Now, listen very carefully, okay? With fibrocystic disease, you do an aspiration, but not a fine needle aspiration. Let me explain. They should have never called FNA. They should have called fine needle aspiration fine needle cytology. Because it's confusing when someone comes with fibrocystic disease, you don't do an FNA, you do an aspiration with a big needle. Why? Because, listen carefully, test question, listen carefully. If 3 things happen to that cyst, you're home free. You don't have to do anything else. These are the 3 things. After you stick a big needle in it, not a fine needle, a big needle. Number 1, the mass completely goes away. Number 2, the fluid is not bloody. Number 3, the lump does not come back. If those 3 things happen, you don't have to do nothing. Let me repeat it. This is not called fine needle aspiration. It's called aspiration. It's too bad that they use the same word. It's not a fine needle. In this situation, use like an 18-gauge needle, big needle. If 3 things happen, mass goes away completely, the fluid is not bloody, and it doesn't come back, you're home free. If any of those don't happen, you biopsy. If any of those don't happen, you biopsy. That's fibrocystic disease. All right? That's fibrocystic disease. And usually, the exams we get for women over the age of 30 are mammograms and ultrasound. Mammograms and ultrasound. But let me ask you a test question. Which is the best imaging study for the breast? MRI. Why do we not then get MRIs on patients routinely? That's correct, Eva, cost. But what's going to happen? By the time you guys get into practice, every woman will be getting MRIs, and you know what they'll say to you? They'll say, you mean you really used to get mammograms on patients? You used to give x-ray to patients? Seriously, MRIs will be done on women. There will be no more mammograms. Because MRI, no radiation. But in this day and age, for the test, if a woman's over 30, mammogram, ultrasound, okay? And Arlene, you're kind of right. A mammogram is kind of a barbaric procedure. You're giving x-ray, you're squishing the breast, it hurts. You know, why not get an MRI? Because we can't. The insurance company, I can talk till I'm blue in the face. The insurance company will, I mean, the patient can pay for it, but the insurance company won't cover it. Okay. So remember, when someone has fibrocystic disease, lumps that come and go, you don't do an FNA, you do a big needle aspiration. Okay? All right. Number 5. A woman has a bloody discharge from her nipple. Listen to me carefully. The most common cause of blood from the nipple is an intraductal papilloma. But every time there is blood in the nipple, you must rule out cancer. That's so important. I'm going to say it again. The most common reason for blood in the nipple is intraductal papilloma. But every time you have blood from the nipple, you must rule out cancer. Meaning, you got to find that papilloma. You got to find that papilloma. You got to do a mammogram, an ultrasound. Sometimes you have to do a ductogram, but you have to biopsy it and prove it's not a cancer. Does everyone understand that? Be safe. Oh, Arlene, I like that. Be safe. Be safe. Does everyone understand that? You can't just say that to a patient. Oh, most likely it's an intraductal papilloma. You got to prove it. Histologically, you got to prove it. Okay? Now, number 6. You have a lactating woman who comes in with a red-hot breast. What's the diagnosis? Mastitis. Very, very common. Listen to me carefully, guys. If a woman is not lactating and comes in with what looks like a mastitis, what is that? Cancer. Inflammatory cancer. That's so important. I'm going to say it again. If you see a woman who has what looks like a mastitis and she's not menstruating, if she's not lactating, you better rule out cancer. Okay? Don't forget that. Don't forget that. All right. These were simple things. And now we get talking about cancer of the breast. I'm going to give you my 30-second lecture because you never get a good, easy, structured lecture on breast cancer. And I'm going to give it to you now. Okay? Very simple. It'll answer all the questions you need to know for the test and life. Listen to me carefully. Breast cancer is generally divided by 2 ways: histologically and architecturally. Histologically, ductal and lobular. Architecturally, invasive and in situ. So therefore, we have 4 types of cancer: invasive ductal, in situ ductal, invasive lobular, in situ lobular. Those are the four, basically. I am now going to tell you on each of those the options for treatment, which you must memorize. Invasive ductal, the most common, invasive ductal. The two options are modified mastectomy, which means you would remove the breast and sample the lymph nodes, or lumpectomy, radiation, and sample the lymph nodes. I'm going to repeat that. Invasive ductal, either modified mastectomy. We don't say modified radical. Guys, we don't use that word. That word is now a politically incorrect word. It technically is called a modified radical mastectomy. Forget the radical. People don't like that word. Modified mastectomy, which is removal of the breast and sample the lymph nodes, or a lumpectomy, radiation, and axillary sampling. That is invasive ductal. The next one is in situ ductal. We thought that in situ ductal was a prelude to invasive. Apples and oranges. In situ ductal does not metastasize. In situ ductal does not metastasize. So therefore, the two options for in situ ductal are simple mastectomy or lumpectomy and radiation. Simple mastectomy or lumpectomy and radiation. The next one we talk about is invasive lobular. And invasive lobular is exactly like invasive ductal, except you have to think about one thing. What's the difference between lobular and ductal? Starts with a B. Bilateral. So invasive lobular is treated in the same way that invasive ductal is, except you got to think about bilateral. Finally, you've got in situ lobular. We don't know what in situ lobular is. We don't know if it's a cancer. So do you know what we call it? A tumor marker. A tumor marker. Just like CEA, alpha-fetoprotein, CA125, etc., etc. So you don't do really anything with that except watch it. So let me summarize once again this whole thing. It's so easy. Breast cancer is divided up histologically and architecturally. Histologically in ductal and lobular. Architecturally invasive in situ. So there's four things. Invasive ductal, the most common. The most common. The two options for treatment are modified mastectomy, don't say radical, modified mastectomy, which is removal of the breast and axillary sampling, or lumpectomy, radiation, and axillary sampling. Ductal carcinoma in situ is totally different than invasive. It does not metastasize. So therefore, the two operations for ductal carcinoma in situ, simple mastectomy or lumpectomy and radiation. Invasive lobular is just like invasive ductal. Same options, except you always have to think about what? Bilaterality. And then finally, lobular in situ. We have no idea what it is. We don't know if it's a cancer. We call it a tumor marker, like CEA, alpha-fetoprotein, something like that. And we watch it. We watch it. We watch that patient like a hawk. That's it. It's not that difficult. So let's look at now the vignettes. Number 7, a woman has a hard mass in her right breast. Guys, you do an FNA. An FNA. In real life, you do a mammogram and ultrasound first. But for the test, what are you going to get? Write it down. I want to see you do it. Come on, what do you get for the test? FNA. Number 8. Test question number 8. A woman has a mass in her breast and she's pregnant. And you do an FNA and it's cancer. Test question. Test question. Do you terminate the pregnancy because of the breast cancer? No, you do not. Classic test question. Number 9, 10, 11, and 12, all they do is show you that breast cancer can look in different ways. 9 shows an orange peel. It looks like an orange peel. 10, a retracted nipple. 11, you've got, it looks like they have a mastitis. Number 12, it looks like eczema. So guys, the bottom line is breast cancers can look real different. So you got to look for that orange peel, that retraction, that inflammation, or even the eczema. But they're all breast cancers. Here is a test question, number 13, that you will always get asked. Number 13, a woman was working around a house and she hit herself with a broom handle in her breast and felt a lump. And she comes to you and you evaluate her. What should you do with the lump? Is that lump most likely secondary to trauma, or is that lump most likely a cancer? It's a cancer. Why? Because most probably the trauma brought attention to the lump. Guys, this is a classic test question. You cannot ignore it. Now, if you're lucky, it's all from trauma. But you cannot say to the patient, okay, go home, put warm compresses on it, relax, and don't worry. You must evaluate it like you evaluate any other breast mass. And guys, I cannot tell you how many times I've gone like this. And I do a FNA and it turns out to be a cancer. And what happens is the patient hurt themselves, but it draw attention to the lump. Don't forget this. Classic test question. I guarantee it's on the test. Number 14. Guys, listen carefully. This is hard stuff, but it's going to be on the test. A woman has a mass, one mass in her armpit. Solitary mass. She has no other lymph nodes anywhere else. Her breast exam is normal. Your next step is Mammogram. Mammogram. Why? Can you have non-palpable mammographic abnormalities? Yes. Guys, that's a classic test question. One lump in the armpit, your exam is negative, you get a mammogram. Do you understand? Non-palpable mammographic abnormalities. Number 15. A woman has new microcalcifications. Do you just watch the microcalcifications? Do you just watch them? What do? You biopsy them. Absolutely. Can you have a non-palpable mammographic abnormality? Yes. 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 Okay. When we look at number 16 and 17, things like that, if a woman has a small breast, do you do a lumpectomy? Is it smart to do a lumpectomy? No. Why is it not smart to do a lumpectomy in a small-breasted woman? Deformity, very good. Cosmetic, you will leave them with a deformed breast and they will hate you. If someone has small breasts, you do a mastectomy and reconstruct them. You do not do a lumpectomy. You use your head. Use your head. Don't make a deformed breast. You will have a patient who will hate you. Truly hate you. Because if they have a deformed breast, they can't wear external prosthesis. Guys, the patient will hate you. Use your head. If a patient has small breasts, suggest a mastectomy. All right? Now, let's look at number 22. Oh, Samira, you asked a good question. Why wouldn't you do an FNA of the lymph node first in case 14 and then do a mammogram? Samira, let me ask you a question. Do you do invasive first or you do non-invasive first? Which do you do first? Non-invasive. If you did an FNA, would it be wrong? But someone would say, what's wrong with you? You still need a mammogram. And you're correct. If the lymph node is negative, you'd still need a mammogram. Absolutely correct. So you always do non-invasive before invasive. Good question. Good question. Good question. Now, let's look at number 22. This is an important question. You got a woman. I'm going to change number 22 a little bit. She comes to your office. And she comes to your office and she stinks of perfume. Nice woman, dressed very nicely, but stinks of perfume. She takes off her bra and she has a fungating mass in her breast. A fungating mass. And guys, she doesn't acknowledge it. She doesn't acknowledge it. Meaning, you want to say, oh, what were you doing? Why? They don't. It's a psychiatric problem. And usually, these fungating masses are widely metastatic. You usually can't do anything but chemotherapy and radiation therapy. Guys, this is a psychiatric disorder. Kind of like that woman with that big hernia I told you about, where she just doesn't get it. And has anyone ever seen this? Where you have a patient who has a gross fungating mass. And guys, why did she wear so much perfume? Why did she wear so much perfume? Right, because it smells. It's necrotic. This is a psychiatric disorder. A psychiatric disorder. All right? Now, number 23, 24, 25, and 26. Okay? I don't want you to spend more than a minute on those because I'm going to tell you what you need to know. Oh, let me answer this question, Emanata. This is a good question. For your purposes, a core biopsy and an FNA are the same. In real life, a core biopsy is a little bigger, and it gives you more tissue. But for your purposes, you can call both of those a needle biopsy. Do you understand? Core biopsy, true cut biopsy, FNA, for your purposes, they are needle biopsies. The only difference, a core is bigger than a needle. That's all. That's all. That's all. Good question. Good question. Now, guys, listen to me carefully. If you ask oncologists about breast cancer, you will not get 10 oncologists to agree. And if you can't get 10 oncologists to agree, you'll never get the right answers on the test, and neither will I. Now, I'm being very honest with you. I don't get the right answers. Why? Because everyone. Oh, Maya, if you can do a core biopsy, it's a little bit better than an FNA, but you will not be, that's a clinical thing when you get into step 3 otherwise. All they care about is that you do a needle biopsy. Do you understand? Because it's easier to diagnose with more tissue than it is with an FNA because it's cytology. That's all. That's all. You get more tissue, just like Eileen said. That's all. All right? Common horse sense, okay? All right. Listen to me about the oncology. It's very, very important. You won't get consistent answers, so I'm going to teach you concepts which will help you for the test and life. Generally speaking, if a patient is progesterone and estrogen positive, you treat them with hormonal manipulation. The drugs, tamoxifen, stuff like that. If someone is progesterone positive and estrogen positive, you treat them with hormonal manipulation, generally speaking. Okay? If someone has positive lymph nodes, you generally speaking treat them with chemotherapy. Those are the basic concepts. If they're estrogen and progesterone positive, you treat with hormonal manipulation. If they're positive lymph nodes, you treat with chemotherapy. Are there exceptions? Gigantic exceptions. I want you to understand that you will get people who have negative lymph nodes and be treated for a year with chemotherapy. You will have patients who are negative progesterone and estrogen positive and be treated with hormonal manipulation. But for the test, and for step 2, and for your life at this stage, estrogen positive, progesterone positive, hormonal manipulation. Positive lymph nodes, chemotherapy. And then finally, if you had a woman, number 25 and 26, who has bad headaches, and they had breast cancer in the past, what are you thinking about? Mets. Same way, if you had a patient who had breast cancer and they have back pain, what are you thinking about? Mets. And by the way, could you just tell me, what is the most common primary in a woman for pathologic fracture? Breast. Could you tell me what the most common primary for a male is for pathologic fractures? Lung. Could you tell me what the most common primary for a male for any bony mets? Prostate. Very, very good. All right. If you remember just what I told you, you will know more than you need to know for the test and for life. Very, very good. Guys, I want to tell you one thing to show you how things have changed. You're not going to believe what I'm going to tell you. When I was in my training, do you know what we used to do? Every premenopausal woman, every premenopausal woman who had breast cancer, we used to do bilateral adrenalectomies and bilateral oophorectomies on them. Every single patient. We did them so often that we called them adrenufs. Adrenalectomy, oophorectomy, adrenufs. We'd put them on their stomach, we'd resect their 12th rib, take out their adrenals, flip them over, open up, take out their ovaries. It was thought, in those days, it was thought that in a premenopausal person who had breast cancer, by taking out their adrenal glands and taking out their ovaries, you're helping them. Guys, if you did that today, you wouldn't only be sued, you would be arrested. No, you would be arrested for what? Assault and battery. It's amazing, guys. It's amazing that that was the standard of care in the best hospital, one of the best hospitals in the world. I mean, you know, where I trained in Boston and to Harvard. You know that, and this was the standard of care. And they're going to say the same thing to you when you go out and practice, because things are going to change again. They will. They will. The idea was to prevent, problems. Medicine evolves. What year was this, Mark? I was in my training from 1977 to 1983. Long time ago. All right? The same will be true in 20 years. You're correct. You're kind, Justin. Thank you. Oh, true. Where do you work at Harvard? I was at the Brigham. Where do you work at Harvard? You work at the Brigham, but when I was at the Brigham, they called it the Peter Bent Brigham. You call it what? The Brigham and Women's Hospital, but it used to be the Peter Bent Brigham. All right. Now it's Brigham and Women's. Oh, where do you live, Arturo? Where do you live in Boston? Brookline. I used to live in Brookline. Where do you live in Brookline? Where? Oh, you live in a nice area. I lived off of Longwood. I couldn't afford an apartment. I rented a room in a house. Guys, I got $6,000 a year. That was my payment when I was an intern. $6,000 a year. I rented a room in a house. That's where I lived, off of Longwood Avenue in Brookline. Do you remember where that is? On the way to the West Roxbury VA. You know what I'm talking about, Arturo? God, what a small world. That's incredible. All right, guys. I want to make one more comment about breast cancer. I think that Angelina Jolie did a great thing. I really do. I'm very serious about this. She has brought so much awareness to the public, the fact that she went public about what she did. And yeah, she had BRCA, but that's not the point. The point is that all of a sudden, she talked about it. She talked about and did a mastectomy and then did oophorectomy. I'm telling you, she did a great thing for humanity, because women now feel more comfortable talking about it because someone like her, a movie star and stuff, did this. And mark my words, Nada, you're correct. You mark my words. She will be nominated for the Nobel Peace Prize. I guarantee it. I really mean it. She will be nominated for the Nobel Peace Prize. She will. Not Brad Pitt, but her. Okay? All right. I like Brad Pitt, but she's a phenomenal girl. She really is phenomenal. All right. Now, Are you ready? Now we go to one of my favorite areas, okay? Diseases of the endocrine system. Endocrine system, okay? Number one, we start out with a solitary thyroid nodule. If someone has multiple thyroid nodules, what are you thinking? What are you thinking? What are you thinking? Multinodular goiter. But if someone has a solitary nodule, you must rule out what? Cancer, cancer. Now, just like I said for breast, for the test, for the test, for the test, for the test, your first invasive procedure is an FNA. Guys, in real life, we don't do this. But I just want you to know, for the test, for the test, for the test, FNA. Now, when we don't do an FNA straight away, we will do an ultrasound to see if it's solid or cystic. And sometimes we'll do a thyroid scan to see if it is, come on, hot or cold. And in those instances, if it's cold and solid, what do we do? Cancer. All right. But for the test, for the test, for the test, FNA is your first step. Okay? Now, watch me carefully. The most common type of thyroid cancer up here is papillary carcinoma of the thyroid. Papillary carcinoma of the thyroid histologically has Psammoma bodies. Can't spell it, but I can say it. Psammoma bodies. It spreads through the lymphatics. The treatment is total thyroidectomy. And the 5-year survival is 90%. Pretty good cancer. That's papillary up here. The next one, which is also good right here, is called follicular carcinoma. Follicular carcinoma starts where? In the follicles. It spreads by the bloodstream. Hematogenous. Very good, Diva. The treatment is total thyroidectomy. And the 5-year survival is 80%. Here is the test question for follicular. Remember I told you that the first test you do is an FNA? If you do an FNA and it is follicular cancer, all they will tell you on pathology is you have follicle cells. The classic test question is this. You do an FNA on follicular you do an FNA and you get back follicle cells, your next step is surgery. They cannot tell benign or malignant by an FNA in follicular carcinoma. So important, I'm going to say it again. You cannot tell benign or malignant by an FNA in follicular carcinoma. So here's papillary, here's follicular, and then down here is something called medullary carcinoma of the thyroid. Where does medullary carcinoma of the thyroid come from? Where does it come from? Very good, the C cells. And what is the tumor marker of medullary carcinoma? Calcitonin. Very good. Every time you have a medullary carcinoma of the thyroid, you must always think about MEN2. What's in MEN2? Medullary carcinoma of the thyroid, parathyroid, and pheochromocytoma. Test question. If you had MEN2, which would you do first? The pheo or the medullary carcinoma? The pheo. Very good. Very good. So guys, medullary carcinoma, every time you got a medullary carcinoma, you have to think about MEN2. Why would you do the pheo first? If you ever operate on a patient who has a pheo, and you're not touching the pheo, the blood pressures will be like this. They'll die. The anesthesiologist will hate you. All right. The treatment of a medullary carcinoma of the thyroid is total thyroidectomy. The 5-year survival is 40%. So it's not a great cancer. Finally, in my shoes is anaplastic carcinoma. There is no 5-year survival for anaplastic carcinoma. They die. The only treatment for anaplastic carcinoma is palliative, and the palliative treatment is tracheostomy. Let me repeat everything I just said. Patient comes in with a solitary mass of the thyroid. For the test, you do an FNA. But in your office, you'll probably start with an ultrasound and maybe do a thyroid scan. And if it's cold and solid, it's usually malignant. Papillary carcinoma of the thyroid, most common, spreads lymphatics, has somoma bodies. Treatment, total thyroid. 5-year survival, 90%. Good cancer. Next one, follicular carcinoma. Starts in the follicles, spreads through the bloodstream. Treatment, total thyroidectomy. 5-year survival, 80%. What's the important test question here? If you do an FNA and they tell you you have follicle cells, your next step is surgery. Why? They can't tell follicular cancer from a benign nodule by an FNA. Down here is medullary carcinoma of the thyroid from the parafollicular C cells. Calcitonin is the tumor marker. Every time you have a medullary carcinoma, you think about what? MEN2, parathyroid, pheo, and medullary carcinoma. If you have it, you always operate on the pheo first. The treatment of the medullary carcinoma thyroid is a total, and the 5-year survival is 40%. Down in my shoes is anaplastic carcinoma. There is no 5-year survival. The only palliative treatment is a tracheostomy. That is thyroid cancer, more than you'll ever need to know about that. So then we get to number 4, and a patient has hypercalcemia. Hypercalcemia. All right? Is hypercalcemia bad? Is hypercalcemia bad? Yes. What symptoms do you get? I want you to remember this mnemonic, but never say it out loud. Stones, bones, abdominal groans, and psychic moans. Bones, stones, abdominal groans, and psychic moans. What does that mean? Stones, kidney stones. Bones, pathologic fracture. Abdominal pain, groans, and craziness, psychic moans. Stones, bones, abdominal groans, and psychic moans. Guys, we all think of that. We all say it to ourselves. But when your professor, like me, asks you, what are the symptoms of hypercalcemia? Don't say, oh, stones, bones, abdominal groans, and psychic moans. Do you understand that? Don't say that. Stones, kidney stones, bones, pathologic fractures, abdominal groans, belly pain, psychic moans, mental changes. Tell me, what is the most common cause of hypercalcemia? No. No. Cancer. Very good, Clive. Very good. The number one cause is cancer. The second most common cause of hypercalcemia is hyperparathyroidism. In hyperparathyroidism, the most common cause of hyperparathyroidism is a parathyroid adenoma. The second most common cause of hyperparathyroidism is hyperplasia of the parathyroid glands. Hyperplasia. Let me repeat all that. The number one cause of hypercalcemia is cancer. The second most common cause is primary hyperparathyroidism. The number one cause of primary hyperparathyroidism is an adenoma, parathyroid adenoma. The second most common cause of primary hyperparathyroidism is parathyroid hyperplasia. So if you had a patient with elevated parathormone levels and elevated calcium, they have primary hyperparathyroidism. And if you open their neck and you find parathyroid adenoma, what do you do? What do you do? You take out the parathyroid adenoma. What if you find parathyroid hyperplasia? What do? You do a 3.5 gland parathyroidectomy. A 3.5 gland parathyroidectomy. Oh, and Emery, why were you pimped on this today? Come on. It's not hard. A parathyroid adenoma, you take it out. Parathyroid hyperplasia, you do 3.5 glands. All right? Very, very simple. All right? Very, very simple. Okay? Why do you take 3.5? Because you want to take out most of the tissue that's causing the hypercalcemia. Why is it 3.5? Why are all the glands hyperplastic? I don't know. If you can tell me, you'll win the Nobel Prize. We don't know. We take out most of the glands. We leave in just half of a gland. That's all. Just half. The parathyroid glands are not big glands. They're little itty bitty glands. You take out 3.5 glands. You just leave, negative feedback. There's negative feedback. But we don't know why you get hyperplasia in the first place. And if you figure it out, you'll be richer than Bill Gates. All right? Now, number 5. A woman has moon facies, buffalo hump, and bruised extremities. What disease does she have? Cushing's. Cushing's. Test question, guys. Test question. What is the most common cause of Cushing's? Test question. Iatrogenic. All right, you guys got giving steroids as an outpatient. Absolutely. The most common cause of Cushing's. Without question. Test question. But forgetting about iatrogenic, the most common cause of Cushing's is something called, very good, a pituitary adenoma. And that's called Cushing's disease. A pituitary adenoma. The second most common cause of Cushing's is adrenal, either a tumor or hyperplasia. And what's the third most common cause? Ectopic, from cancers, metastatic cancers. So let's say that all again, guys. Very, very simple. And this is your test question. It's no harder than this. The most common cause of Cushing's in the world is iatrogenic, us giving steroids. But forgetting about iatrogenic, the most common cause is a pituitary adenoma. All right? The second most common cause is an adrenal tumor or hyperplasia. And the third most common cause, the least most common cause, is ectopic, from cancers. And that's it. Has anyone ever seen a Cushing's patient? Can you tell Cushing's just by looking at them? Yes. They look very, very specific. They don't look fat. They look specifically like Cushing's. From a mile off, that's true. All right? And that's Cushing's, okay? Number 6. This is very easy. You have a woman who has unbelievable peptic ulcer disease. You treated her for H. pylori, and she has multiple ulcers. Guys, this isn't H. pylori. This isn't regular peptic ulcer disease. This is Zollinger-Ellison syndrome. It's very, very rare. You measure serum gastrin, and you get a CAT scan of their pancreas and take out the tumor. All right? It's so rare, I mean, it's just unbelievably rare. Okay? That's why. Oh, why do they have diarrhea? That's an excellent question. Well, when you have increased gastrin, what happens is that, very good, Diva, that's correct. It degrades the pancreatic enzymes, and you get steatorrhea. Yeah, good, very good. Oh, Diva, you get the gold star. Let's give Diva, come on. Very nice. I like that, Diva. Very, very good. All right. See number 7? Guys, do you see the question number 7? Okay, 7. Would you take your black pen and X it out? I don't want you to look at it. It's not a good question. Would you please X it out? I don't want you ever to look at it again. Okay? Thank you. Finally, before we take a break, number 8. Look at number 8. I've never seen this in my life, but you're going to be tested on it. You have a patient with severe migratory necrolytic dermatitis. Guys, I have no idea what severe migratory necrolytic dermatitis means. I don't. Meaning severe, migratory, moves around, necrolytic, dead tissue, dermatitis. To a dermatologist, this means something. Guys, I'm telling you straight. If you ever see these words, severe migratory necrolytic dermatitis, only one thing you have to think about: a glucogonoma. Alright? That's all you have to know. You measure glucagon levels and get a CT scan of the pancreas and take it out. This is so rare, I have never seen it. You will never see it. But on your test, they're going to ask you one question. Guys, memorize this. They will say a patient has severe migratory necrolytic dermatitis, and you are to answer glucogonoma. Do you understand that? Everyone got it? I've never seen this. I've only read about it. Why they test you on it, I don't know. But they will, and all you got to do is look at that word, severe migratory necrolytic dermatitis. Arlene, that's actually true. If you listen to what I say and kind of picture me saying it, you will get the answers. That actually is very, very true. Alright guys, you did real well on that. Let's take a little break and get something to eat and drink. Alrighty, let's do it. All right. Very, very good. Okay. Arlene and Amrita, that is very nice of what you said. I really appreciate it. Again, I just want to tell you something. The hardest thing for me in doing this is I can't see you guys. As you probably can tell, I'm a people person. I went into medicine for two reasons. I like science and I like people. And I try to picture what you guys are like, meaning by what you say. In other words, and I try to get that's why I ask you what you do on the break and this and that, and I kind of get ideas about you guys. And I thank you. It's very, very nice of you to say those things. I will just tell you something, that when people ask me what I'm most proud of, the first thing is my kids, without question. But the second thing is my influence on young people. And that to me is the most important thing. Seriously, very, very seriously. And maybe I'll tell you at the end of this course, my life was made by mentors. It was made by mentors. And I never would end up where I am now if it weren't for people who took me under their wing. And thank you, Claudia, and that means a great deal to me. I would never end up, I will tell you at the end of this course, your professor here went down a totally different road. And it was because of mentors, and that's why I tell you stories. Mark, thank you for what you did. And these are pretty important stories because they teach you about character, and this is important. It teaches you about, character, what you're like as a person, integrity, and I want you all not only to be smart, but I want you to be good people. I tell you these stories for a reason. I want to be a mentor to you, not only intellectually, but as a role model. So, because you guys get so many crappy role models, please excuse me, but I see it in my own career. I see professors who don't give a crap about, young people, and I hate it. And they always say, "Oh, Mark, you spoon feed your students and residents." I said, they have to be guided. They have to be mentored. And, I take it very, very seriously. So I really appreciate your comments. And the stories that I tell you are so important, guys. They're just as important for you because they develop you. And you've been around doctors who have been idiots, haven't you? I mean, tell me the truth. I know you have. I've been around millions of doctors who have been idiots. And you don't ever want to be like that. Ever, 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 ever. Isri, that's a very nice thing. That's a very, very... And, guys, it's just something that's important to me, but I want it to be important to you. Because one of your obligations, listen to me, guys, as physicians, one of your obligations is when you have students to teach them, to guide them, to treat them well. You can be tough, you can be serious, but always respectful, always nice, and always polite. Always, always, always. And those are things that I teach you, and I'm going to tell you later on, meaning in the next number of days, things that I did that weren't good things, and that I learned from it. But I tell you it so that I want you to know mistakes I made, and you don't, you're not perfect. You make mistakes, you learn from them, and you improve. So that's really important for me. And I'm sorry for talking about it now, but your wonderful things that you've read, what you've written, I'm sorry, really touched my heart. And it means a lot, seriously, more than anything else. It's the most important thing that I can make a difference in your life, that you'll remember who I am. Seriously, I'm serious. I am a dinosaur. There's no question about that. But I want to be a dinosaur in your life. Meaning I want you to remember who I am, and at least one of the things that I told you, stories or anything like that. I'm serious about that. I mean it. It's more than just the textbook things, the questions, the things I ask you. I'm training you to be a great physician, no matter what your specialty is. I mean it. That's very nice. You are, well, I love you guys too. I mean it. You guys are, I just wish I could see you. Someday they're going to have a thing where your picture will come up next to your name. I mean it. They got to be able to invent that. Can't you guys invent that? You're computer people. Can't you invent it? Well, I'm not 89 years old, Justin. I'm not far from that. Come on. I'm still a dinosaur. Come on, Justin. Oh, Justin, you're terrible. Oh, you are terrible. Are you kidding? All right. Guys, let's go on our last subject of the evening. All right. Ready? First tell me what you did. First tell me what you did. Tell me what you did. Come on. Folded, Alicia. Folded. Prepped for dinner. Drank water. Not too much. Red Bull. Daniel, you're not supposed to. Check in your baby. Changed the diaper. Celeste. Tea. Ate muffins. What kind of muffins, Aminata? I don't know what this new Ninja food processor is, but I've heard about it. Strawberry cheese. Oh. Ooh. Now you're making me hungry. It is great? Oh, I'll bet you it is. Blueberries. Don't say that. I'm getting... This is getting me hungry. Are you guys hungry? Are you hungry? I am. I am. All right. Good. Well, I want you to see this good sounding food. All right, very good. Okay, guys. For our last session, let's get ready. Here we go. Not bad, a snack. Okay, Jose, what did you have for a snack? Nothing? Water? Good snack, Jose. Jose, that must have tasted great, right? A snack. What'd you do? Take it out of the faucet and just drink it? Come on, Jose. All right. Okay, guys. Listen to me carefully. By the way, when you're talking about eating, do you know what's wrong with doctors? Doctors never take their time and enjoy eating. You're correct, Arlene. They don't. You learn to wolf down your food, eat it real fast, and you don't enjoy it. Let me ask you guys a question. Have you ever gone out to dinner with people who aren't physicians, and you finish like, hours before they finish? Yeah. And you're just sitting there, and you're waiting for the coffee, and they're still eating, and stuff like that. Physicians, it's a terrible thing, but we don't enjoy, and I know, Alicia, same way. I have to I can't eat slowly. I just can't. Do you know why? Because in surgery, if you don't grab something and eat fast, you might not be able to eat at all. Oh, did you? So 3 tacos on your first date before your husband did. Eat when you can, sleep when you can. You're correct. Ah, Celeste, that's cute. He fell in love. Well, he's a lucky guy. Alrighty. See, I love talking like this with you. I really do. I learn about you that way, and to me, that's important just as much as teaching you. Alrighty, surgical hypertension. Guys, remember something. When we talk about surgical hypertension, we're not talking about essential hypertension. We're not talking about the regular hypertension that people come in. Surgical hypertension is a very special entity. Now, the way they present it in the vignettes, I'm going to make it easier for you, and you'll be able to know these vignettes like that and know everything for the test and everything for life. Listen to me carefully. Under the category of surgical hypertension, we're going to start with sustained hypertension. Sustained hypertension, meaning hypertension that stays there. Alright. There are two reasons why you have sustained hypertension. One of the reasons is a tumor that is in your adrenal gland that secretes aldosterone. What is that called? Conn syndrome. And it's a hyperaldosterone secreting tumor. That's one of the reasons why you get sustained surgical hypertension. A tumor in the adrenal gland. The second reason why you get sustained surgical hypertension is renal artery stenosis. Because when you have renal artery stenosis, you get increased aldosterone. So immediately, if you see a patient and they have Conn syndrome or renal artery stenosis, how chemically can you differentiate between the two? The patient with the Conn syndrome, their renin will be low. In renal artery stenosis, their renin will be high. Very good. So in sustained surgical hypertension, you have Conn syndrome with a low renin, and you have renal artery stenosis with a high renin. Therefore, listen carefully, guys, test question. Your Conn syndrome is called primary hyperaldosteronemia, and your renal artery stenosis is called secondary hyperaldosteronemia. Your Conn's is called primary hyperaldosteronemia, and your renal artery stenosis is called secondary hyperaldosteronemia. Meaning, I'm repeating it, I want to make sure you absolutely understand this. Conn syndrome, primary hyperaldosteronemia, you have a tumor that's producing aldosterone. Your renin is low. In renal artery stenosis, you have secondary hyperaldosteronemia. You got renal artery stenosis, decreased blood adrenal gland for adrenal aldosterone. So therefore, the management of these two types of sustained surgical hypertension are very different. If you have Conn syndrome, you would again get a CAT scan or an MRI, they won't make you choose, of the belly, and you would take out that adrenal gland. Now tell me something. In Conn syndrome, do they have a high or low potassium? very low, very low, very low. Guys, they have some of the lowest potassiums I've ever seen, like 2.2, 2.3. This is a test question I'm going to ask you. People who have aldosteronomas, Conn syndrome, who have hypokalemia, are generally healthy people except for that hypertension. And they will complain about a symptom that is directly related to the potassium. What is that symptom? Not muscle weakness. Not muscle weakness. Not muscle weakness. Guys, listen to what I'm saying. Not muscle weakness, muscle cramps. Muscle cramps. Oh, guys, this is a test question. Classically, they will present this patient. Patient comes in, young and healthy, feels pretty good, except they keep getting cramps in their legs. So the physician measures their blood pressure. Their blood pressure is up to here, and their potassium is down on the ground. That is very, very common for Conn's syndrome. All right? If you talk about someone with renal artery stenosis, and you made that diagnosis initially by secondary hyperaldosteronism, meaning increased renin, there are two types of patients who have renal artery stenosis. The most common is people with atherosclerosis as they get older. And so what happens is their renal arteries get more and more diseased, and they have increased renin, increased aldosterone. But there's a special subset of renal artery stenosis that occurs in young women. What is that called? Fibromuscular dysplasia. They have, and a lot of times, those can be treated by stents. Very, very easy. So in renal artery stenosis, the most common is atherosclerosis, by far, by far. But then you got that subset of young women, fibromuscular dysplasia. These are the two types of sustained surgical hypertension. Again, let me review this with you. You got a patient with sustained surgical hypertension. They both have elevated aldosterone. The one that has primary hyperaldosteronism, meaning they have a decreased renin, is Conn syndrome. They have a low potassium. They complain of muscle cramping. Do an MRI or a CT and take out their adrenal gland. The other patients have a secondary hyperaldosteronism, and they have a high renin. And those patients have renal artery stenosis, and the most common cause is atherosclerosis. But a small subset of women have fibromuscular dysplasia. So guys, on rounds, when you present and you say, I think this patient has sustained surgical hypertension, you should say, I think they have primary hyperaldosteronism. Or, I think they have secondary hyperaldosteronism. Because then you're really telling what's going on. Exactly. Does everyone understand this aspect so far? It's very, very easy. Has anyone ever seen a Conn syndrome? Have any of you guys ever seen a Conn syndrome? It's not common. It's not common. It's usually a young person. So you don't, you don't think about renal artery stenosis. Usually a young person. All right. That's sustained surgical hypertension. Now, guys, get this out of your brain now, okay? No, Isri, here's where I'm going to go. I want you to get the sustained out of your head. Out of your head. Now, we're not talking about sustained surgical hypertension. We're talking about paroxysmal hypertension. What does that mean? Paroxysmal. Goes up and down. One day you'll see the patient in the office, and their blood pressure will be 120/80. The next day you'll see the patient, and the blood pressure will be 200/120. I want you to use the word paroxysmal. Paroxysmal. I want you to use that word, because that's the word that's used on your test and in life. When someone has paroxysmal hypertension, you think about one type of tumor. What is that? A pheochromocytoma. Test question. Tell me some of the symptoms that a pheochromocytoma person would have. Headache, palpitations, flushing, very good, sweating, very good. What else? What else? What am I doing, guys? What else? Look at me. Oh, restlessness. They look like they are going to jump away from your chair. They look like they drank. Who of you guys drink this Red Bull? It looks like they drank 10 Red Bulls. All right? They look more than nervous. They look like they're on drugs. They look like they're on drugs. It is a classic look. In addition to the hypertension, the palpitation, the sweating, the pallor, they're just jumpy like this. Well, it's not exactly cute because they don't look comfortable, Isri. They don't look comfortable. Yes, they look like Arlene, like an ant's nest. They just look, Isri, you don't have to apologize. You don't ever have to apologize to me. This is how you learn. They look like something's not right. Isri, you don't have to apologize. Seriously. They look like something's not right. So, you evaluate them by measuring their norepinephrine and epinephrine. And by the way, guys, in this day and age, we measure cortisol, serum cortisol, we measure norepinephrine, we measure epinephrine, we measure aldosterone. I mean, we measure this. We don't do urinary anymore. We measure the serum because we have the ability to do so. All right? And when you measure norepinephrine and epinephrine in a pheo, it's really high. Every time you have a pheochromocytoma, you must always think about what? MEN2. And the pheo is the most important. The best test is measuring norepinephrine and epinephrine. They will be elevated, okay? Now let me ask you, test question. Test question. Does the pheochromocytoma have to be in the adrenal medulla? No. It can be anywhere along the sympathetic chain. Okay? It can be anywhere. So therefore, a pheochromocytoma is not absolutely an adrenal medullary tumor. It's most commonly there, but it can be anywhere along the sympathetic chain. So you get a CT or an MRI, they won't make you choose. All right? And if you have a pheochromocytoma, you have to prepare that patient preoperatively. How do you prepare, test question, that patient preoperatively? You have to block them alpha and beta. What do you block first, alpha or beta? Alpha, because if you block beta first, they will have unopposed alpha, and their blood pressure will go up to 300, and their eyeballs will pop out. Not really, but they'll have a stroke, okay? Now, one of the things you have to do when you're operating on a pheochromocytoma, even though you gave them alpha and beta blockers, when you start manipulating around the pheo, the blood pressure starts going like this. Now, one of the things that the surgeon has to do, the surgeon has to be a smart surgeon. They don't all of a sudden clamp the adrenal artery or clamp the adrenal vein. Think hard. What would happen if I suddenly clamped the adrenal artery or the adrenal vein? What would be their blood pressure? Boop! Massive hypotension. Massive hypotension. Why? The other adrenal is turned off, I assure you, from the pheochromocytoma. Guys, this isn't on the test, but I want you to understand it. About half an hour before I get to clamp the adrenal vessels, I tell the anesthesiologist, and what they start doing is tanking up the patient. You know what that means? Giving fluids, lots of fluids. And sometimes when I clamp the vessels, they actually have to give them pressors because their blood pressure will go in the toilet. It'll go down. So guys, someone asked me why we operate on a pheo before a medullary carcinoma. If you didn't take out a pheo and you were operating on another part of the body, the blood pressure would be like this. And it's dangerous. Remember I told you what is the common denominator of an intraoperative myocardial infarction? What's the common denominator? What's the common? Hypotension. And then on the other hand, if your blood pressure shoots up to 300, what could you get? What could you get? An MI or a stroke. Oh yeah, absolutely, guys. So you don't ever take those chances. So let me summarize what I said about a pheochromocytoma. A pheochromocytoma is paroxysmal hypertension, not sustained, paroxysmal. The symptoms are all those things you talked about: headache, palpitations, nervousness, fidgetiness, sweating, pallor, sometimes flushing. They look awful. They look terrible. And you make the diagnosis by measuring norepinephrine and epinephrine levels. And what you do is you get a CT or an MRI, and does the tumor have to be in the adrenal medulla? No. Now, I have to tell you something that unfortunately is going to be on your test. And it's one of those questions that are a little pimpy, but I want you to know this. Guys, there is a ganglia, a sympathetic ganglia, at the bifurcation of the aorta. It has an eponym to it. Anyone know what this is? The organ of Zuckerkandl. Jeremiah, you get the gold star. It's called the organ of Zuckerkandl. K-A-N-D-L. Give him a clap. Come on. Why do I tell you that? Guys, you got to memorize it. I'll tell you why. Because they're going to, on the test, and I'm just telling you, they're going to say a patient has a tumor of the organ of Zuckerkandl. What is this tumor? It's a pheochromocytoma. pheochromocytoma. Guys, memorize that, please. At the bifurcation of the aorta, the sympathetic ganglions are called the organ of Zuckerkandl. Just spell it Zuckerkandle. Zuckerkandl. There's nothing that's spelled like it. Zuckerkandl. And if you ever want to be impress your professor, say to the professor, have you ever seen a sympathetic ganglion at the organ of Zuckerkandl? And you know, maybe they'll not know, and then you'll be able to say, oh yes, this is at the bifurcation of the aorta, and this is a pheochromocytoma. Oh, very good. Remember, on a pheochromocytoma, you must block the pheochromocytoma alpha, then beta, and then most importantly, intraoperatively, you have to start telling the anesthesiologist when you get to clamping, because they have to load up that patient with fluids and sometimes even give pressors. All right? Let me ask you a question I haven't asked you. Has anyone ever seen a pheo? So most of you have not. And it's not common tumor, but once you see it, you'll never forget the patient. You really won't. All right, very, very good. You guys are perfect. Let's do... Oh, you participated in the surgery. Did you enjoy it, Arlene? Yeah, it's kind of interesting. It's amazing how delicately balanced we are. You know what I mean? As humans. Little things like that can throw us way off. I mean it. All right. Finally, when we talk about surgical hypertension, listen carefully, guys. We talk about sustained surgical hypertension, which is a primary hyperaldosteronemia, which is a CONS, or a secondary hyperaldosteronemia, which is renal stenosis. We talked about paroxysmal surgical hypertension, that's a pheo, and you always think about MEN too. But then we talk about one other disorder which kind of falls into surgical hypertension, kind of not in one location, and that is called coarctation of the aorta. Coarctation of the aorta. When someone has coarctation, they will have hypertension of their upper extremities and hypotension of their lower extremities, meaning you feel their femoral pulses and they're very weak, and yet they have bounding pulses up here. And it's due to a congenital narrowing of the aorta. When you get a chest x-ray on patients who have coarc, they have something called notching of the ribs. Notching of the ribs. What is notching of the ribs due to? Collateral circulation through what vessels? The intercostal arteries. Very, very good. The intercostal arteries. So when we make a diagnosis of coarctation of the aorta, we obviously repair it. It's not something that is common. Can I ask you guys, have you ever seen coarctation of the aorta? You have. All right, well, I'm impressed that you've seen it, because it's really, really not common. It can happen in babies, but it's usually when they get a little older, and you notice the chest X-ray looks abnormal and their blood pressures are low in the groin and high up here. But that's coarctation of the aorta. All right? Okay. Questions on what I have been talking about? All right, listen to me carefully. Because we're way, way, way ahead, for the next few minutes, let me answer any questions, because I don't want to get into the next subject because we're way, way ahead of ourselves. Ask me questions about absolutely anything we talked about, all right? Or anything you want to talk about. Guys, you've done great today. I mean, you were really super today. Go ahead. Any questions? Any things you don't understand? How you knew you will be a good surgeon? Oh, hang on for a second, Claudia. Jeremiah, nowadays, wait a minute, stop. You asked a lot of good questions. Serum catecholamines, by far, are the way to go. If you get urinary catecholamines, is it bad? No. But you can get serum. In 2015, we get serum. The management of stab wounds, I told you, stab wounds was exactly like blunt trauma. If a patient has distended abdomen, shock, or acute abdomen, where are you going? You're going to the OR, okay? If not, you get a what? A CAT scan. Necrotizing pancreatitis is a pancreatic abscess. You've got to get rid of the dead tissue. The best way to review what we covered is to go through it and just pretend, like Arlene said, that she hears the way I explain it. Just to go over it exactly through the vignettes. Is the organ of Zuckercanal close to the superior? No, not really. It's right in the crotch of the aorta. Yeah, don't put your finger in the belly. That's correct. Hepatic adenoma bleeding, if you have a ruptured hepatic... Surgicel? No. Justin, you cut it out. You take your cautery and you cut it out. It's only about this big. You cut it out. Absolutely. Oh, staging breast cancer for treatment, I don't even want to go there because I don't remember it, and that is so complex oncologically. If you want to learn about it, I'm telling you, go ahead, but I'm certainly not going to go into it because I don't know it well because it changes all the time. But I want to answer that question. Where was that question that, I can't remember who asked it, the one before. How do I get to it about being a surgeon? Where was that question? I'm trying to find it. Wait a minute. What am I doing here? I'm trying to... Oh, how do you know... How you knew you'd be a good surgeon. Guys, listen to me carefully, guys. Your specialty that you go into is more related to your personality than your intellectual interest. Meaning, you guys are all the same in the sense you're scientists. You like science. You went into medicine because you like science. I mean, you're all the same in that regard. It's more your personality. Let me explain. Okay? There's one quality that a surgeon has to have to do. And the surgeon has to be able to think in algorithms very rapidly. Meaning, patient, and it's not what I expect. I have to be able to go from plan A to plan B to plan C like that. And sometimes I don't have the full knowledge. I don't have the full knowledge. I have to use judgment. Now, guys, that's a personality thing. Let me ask you a question. Do you ever know people who can't make decisions? I'm really serious about that. You say, do you want to go to a movie or go out to eat? Well, I don't know. They would never make it in surgery because you have to have that ability. It's a personality thing, okay? Let's talk about people like psychiatrists. They have to be tremendously patient. They listen to someone's talk. Pediatricians, oh my God, you're dealing with 3 patients, mom, dad, and a kid. Neurologists, very cerebral, okay? Radiologists, you're always looking at films. You gotta like to use your eyes. Anesthesiologists, those are people who also have to not get bored, because I told you, in anesthesiology, it's seconds of terror, hours of boredom. Pathology are people who usually are intellectuals who love to interpret, because it's hard to look at what what you're seeing. Interventional radiologists are always the coolest of every person. Do you know why? Interventional radiologists, they figure things out. They're mechanics. They're engineers. They figure out how to do things. OBGYN was my second choice in specialty, because I just like OBGYN. GI is a great specialty. You get to do endoscopy as well as treat patients medically. It's like urology. You get to do surgery and also treat patients medically. Internists are quarterbacks. They are people who have to kind of, like a family practitioner, know about a whole bunch of different things. And they're kind of the quarterbacks. The difference between an internist and a family practitioner is a family practitioner will actually do a lot of the things that I do, that OBGYN does, etc. An internist won't, because an internist is a specialty in internal medicine. Do I use the robot? No. No, I have no reason to use a robot, meaning the people who use robots are the thoracic surgeons and the urologists. But I've played with the robot. Have you guys ever tried a robot? Guys, do you ever play with it? It's the neatest thing in the world. You connect it to your fingers, and you look, and it's 3-dimensional. It's not, laparoscopy is 2-dimensional. It's 3-dimensional. You got to try it. Just don't let you try it without a patient. You put it on your fingers, and as you move your fingers, the things move just the way you move your fingers. It's not like laparoscopy. It is phenomenal. I'd like one in my my living room. It'd be fun to use. Seriously, they use it. They're trying general surgery. I don't know where it's going to go with that. Yes, medicine has advanced without any question about that. Do you know how we're going to years from now cure disease? Genetic engineering, without any. My specialty, I'm a general surgeon, Emanata. In other words, I went into general surgeon because I'm a Gemini. What I mean by that, and I'm very serious about that, I fear boredom. And general surgery is a very, very broad field, or at least it used to be. We took care of a whole bunch of different things. And I know it's not that way anymore, but I liked it. I've always liked it because of its broadness. I always have, you know. Well, let me ask you a question. How did you guys choose your specialty? Oh, emergency medicine is a fast-paced, good specialty, and it is a good lifestyle. It's a good lifestyle, you know, because when you're off, you're off. You're off. You don't have to worry about patients. It's a very good lifestyle. But it's tough when you're there. I mean, you know, you're working like a dog. How did you guys decide? OBGYN and internal medicine. Now, that's interesting. Pathology. Pathologists are always the nicest people. You're intellectuals. You like easy. It's not easy. Critical care, exciting. Internal medicine, pulmonology. You're dealing with very, very ill patients. Very fast-moving. Very, very intensive. Without any question. Always an exciting field. But guys, listen to me for a second. Listen for 1 second before we take off for the evening. Listen. You're all the same in the sense that you're all bright. You all like science. You're all the same in that regard. We are. We're all the same. We like science. You pick the specialty that seems to fit your personality. Do you understand what I mean? Like, I'll give you an example. I have a dermatologist friend, and he can't even picture my lifestyle. But I can't picture his lifestyle. In other words, we just have different approaches. Now, advice for the parents who are soon going to be going, I don't understand, Nada. What do you mean by that? Nada, what do you mean? For the parents who are going to be going through residency. Wait, I want to hear what Nada says. Guys. Nada, what do you mean? Type me something. Nada. Type something. Oh, that's a bunch of bullshit. Nada, don't ever listen to people who say things like that. You do what you want to do. Don't ever, I hate that when people say that. Have you guys ever been told that by some doctors that if I had to do it all over again, I wouldn't do it? Have you ever been told that? Well, you forget about what they say. Do you understand that? That is absolutely crappy advice. Now that you do what you want to do, and you go through a challenging residency, and you do what you want to do, you be strong. Don't ever have anyone tell you to stay away. That pisses me off gigantically. You do what you want to do. And I know they say stuff, but you got to do what's here. And when you see you say program directors, Israel, and you say, ask why did you choose that specialty, or should we go, you say the truth. You do what you love. Exactly right. Justin, residency doesn't depend on your grades. It depends on your interview. It depends on how you present yourself. I'm telling you, in the truth, it depends on how you present yourself. The most important thing that you may have noticed about me, I'm not the smartest guy in the world, but I got passion. You know that. You can tell. You know what I mean? I love what I do. I love what I do. Just like, oh, that's nice, held a newborn in your arms and you knew that you had to be a pediatrician. I love that. I love that. Guys, grades don't always get you interviews. Your letters in terms of your personal letters, your story, you got to have faith in yourself. I have faith in you guys. You got to have faith. And yes, Nicole, docs who love what they do make the best kind. And one of the things, and David, you're correct, interview is everything in Canada. And when I interview people, young people like yourself, it's more important the interview than anything else. It really is. Alright, guys, listen. You guys are tired and hungry, and I have to tell you something. You have done a great job tonight. We are way ahead. We are doing wonderful. I want you to enjoy yourself. I want you to have fun. Go eat. Go kiss your kids, or kiss your husband, or kiss your wife, or kiss your mother or father, or do something like that. I want to tell you, you are a truly remarkable group. I really love chatting with you. The only thing that I wish I could see you. It kills me. It really kills me. I will see you tomorrow. Enjoy yourself, and don't do anything crazy. Okay? All right. I'll see you tomorrow. Good night.